Hi friends, so let's start with our rapid revision. All the best to you in all the exams that you appear, and I hope your name is in the list. This is the first page which welcomes you, all of you, to this lecture, also called as Ortho Dhoom Dharaka. This is my daughter. And this was the first slide I made when I started teaching, thanking good God above for enabling me to interact with my students to increase my knowledge. The father of orthopedics, remember the name Nicholas Andre. If this name is not there, you will mark Thomas. And then remember a nephew of Thomas called as Robert Jones, who is the father of modern orthopedics. If you divide a bone and take an X-ray of it, the bone has got upper end or lower end called as ends of a bone, which has got epiphysis, then physis, then metaphysis, and then the middle of a bone also called as a diaphysis. Remember a lesion called as Ewing sarcoma, which is in the diaphysis? It's a question that's asked, and in the metaphysis, remember, it is the most common location for infections and tumor. So M for metaphysis, M for most common. And what you should remember, if you remember this word bone, the word bone in itself has a 1. So this is type 1 collagen. And similarly, if you write down cartilage rather than writing cartilage, it has type 2 collagen. Remember that. And one important thing here, if you see the image of the bone, you will have a labeling of the cartilage. But on the X-ray, that label does not exist because cartilage is radiolucent. It's not seen on X-rays. That's why physis, which is also a growth plate or cartilage, is not seen on X-rays. And now the epiphysis, then the physis, then the metaphysis. If your physis disappears and the epiphysis fuses with the metaphysis, that's called as skeletal maturity. You need to remember the age of skeletal maturity of 6 joints in human body. If you look at this position, which is also called the milking position, the 3 joints that point up, they look up, so they grow more till the age of 18. And the 3 joints that look down, they look down, so they are over early at the age of 16. So this is the age of skeletal maturity. The shoulder, the wrist and the knee, 18 years. The elbow, the hip and the ankle, 16 years. And when you look at the end of a bone called as epiphysis, the terminal end of a bone, there are 4 types of epiphysis. The number 1 is the weight bearing, like the head of femur, pressure epiphysis. Number 2, which is very commonly asked to you, because of a muscle pull, the traction epiphysis, like the trochanterus of femur or tuberosities of humerus. Number 3 are aberrant epiphysis, not of much significance, but what is very commonly asked to you are the atavistic epiphysis, like the coracoid process having a fusion with the scapula. This is something that is very commonly asked to the students. And then comes the physis or the growth plate, which is bridged between the epiphysis and the metaphysis. And when I look at that, from the epiphyseal area, you start the resting zone, the storage disorders, the proliferative zone affecting in dwarfs and giants like Laron syndrome, which is growth hormone deficiency, which is very commonly asked in Jipmer, and scurvy. The maturation zone, which is affected in traumatic disorders, and the zone of calcification, which is just next to the metaphysis, affecting the mineralization disorders like rickets. And then comes the next point. If there is a damage to the maturation zone, there will be a slip or a split of epiphysis. This is called as Salter-Harris classification. So in Salter-Harris classification, the type 1, when there is a slip of the epiphysis, so you can write a 1. Type 2, there is a slip along with the metaphyseal part. This is called as type 2, which is the commonest type, and also called as a Thurston-Holland sign. Type 3 is a split of the epiphysis. So there is an epiphysis split, and if you can see here, you can write a 3 here. So type 3, you can write a 3. And type 4, there is a split of epiphysis with a metaphyseal chunk, so you can very well write a 4 here. So it's just like a 4 here. So 1, 2, 3, 4. And type 5, there is a crushing of the 5. Crushing of the 5. 5 for 5. 5 means physis. The growth plate or cartilage, which is radiolucent, which cannot be seen on an X-ray. And that is why you should remember this very important key point here, that type 5 looks normal on the X-ray. Commonest is type 2. And then we come to the interaction of the hormones on the bone, and I want you to remember one key point. Parathyroid hormone has its receptors on osteoblast, which stimulates the osteoblast, releases the rank ligand, which in itself activates the rank receptors on the osteoclast, which causes the remodeling of the bone. The estrogen and the denosumab, they inhibit the rank ligand, so they inhibit the bone resorption. The bisphosphonates and the calcitonin, they also act on the osteoclast, directly inhibiting the bone resorption. The parathyroid hormone in low dose can directly stimulate the osteoblastic, increasing the osteoblastic proliferation. So, which is the drug of choice if you have bone weakening disorder or osteoporosis? Bisphosphonates, because they are the most potent. Name a drug that acts on the osteoblastic cycle purely. PTH, low dose parathyroid hormone. Remember this. Where are the receptors? PTH. Which cell releases the rank ligand? Remember that, osteoblast. And estrogen and denosumab acts on inhibiting the rank ligand. This is an important cycle that you should remember. Some important movements at the hip. If you have a normal hip, you will have normal internal rotation and abduction. And when you are taking the hip in, the leg goes out, and this is how the internal rotation is shown. External rotation is not clinically significant, so this photograph is rarely shown to you. Remember, you're born like this. The first movement that we do in our life is yes. So atlanto-occipital joint, the first joint in human body, will say yes. The second movement is atlanto-axial joint, which is saying no. So this is a rotational movement. Remember that. When I look at an X-ray, I see a bone made out of cortex, whose break is called the fracture. So fracture is break in the cortex, but I can also see the soft tissue planes outside. And I cannot see the cartilage, as already told to you. And when you look at the bone and the joint space is reduced, which is made out of cartilage, that means you're dealing with arthritis. So if I compare here, you have a beautiful joint space here, which is gone here. So this is a case of cartilage damage, also called as arthritis. And if there is a medial cartilage damage, then in between the two legs, you will form an O. So this is genu varum. Varum means towards the midline. So this is genu varum seen in OA. And if there is a valgus, it will look like R seen in RA. Remember this image forever. O, osteoarthritis, R, rheumatoid arthritis, varum and valgus. And then important key points that you should remember about each joint. Around the shoulder, remember the coracoid is just beneath the clavicle. Remember, it's like a golf ball on a small tee. The ratio between the two is 4:1, between the head of humerus and the glenoid surface. And then around the elbow, remember, it is the capitulum which articulates with the radial head, and it is the capitulum which is the first ossification center to appear around the elbow. Remember the mnemonic crito. This is the capitulum at the age 2 years, radial head 4 years, internal epicondyle or the medial epicondyle at 6 years, trochlea at 8 years, olecranon at 10 years, external epicondyle or the lateral epicondyle at the 12 years. So this is the mnemonic crito, which is the first one to ossify, capitulum. Remember, at the wrist joint is the radiocarpal joint. Ulna is not a significant portion, and on the radius, the boat-like bone is the scaphoid, and just next to it is the lunate. Lunate means the moon, which looks like a moon on the lateral view. And when I look at the lateral view, remember, it is the thumb which is anterior. The first metacarpal is anterior, and on the lateral view that can help you guide whether the dislocation or displacement along with the fractures is occurring anterior or posterior, that is volar or dorsal. And then if I look at the pelvis, I must always remember as a clinician to look at the sacroiliac area, more so in a young man with low backache who might have sacroiliitis, and I might be thinking about a condition called as ankylosing spondylitis, which is HLA-B27 positive. A very, very, very important point you should keep in mind. And similarly in the pelvis, remember to draw the arches between the upper end of femur and the pubic rami, and this arch will be broken in cases of fractures involving the acetabulum or the head of femur, the neck of femur, or a dislocation like you can see here. Remember, CT scan is a specialized investigation to look better at a calcification, or the cortex, it looks white because calcium is white. MRI can help you see the soft tissues, the bone marrow, and can also see the cartilage, which cannot be seen on X-ray or CT scan. And an MRI will have two images, T1 and T2. The T1 image will show you the anatomy. 1 means anatomy, the first prof subject. T2, 2 means second prof subject, the pathology. And how do you pick it up? The water is white on T2. So CSF is water, traumatic edema, inflammatory edema. They are all water, so they can look white on T2 image. It's very common to see a sagittal view of the knee joint where they show you the femur, the tibia, and they mark over the ligaments that bridges between the two, the femur and tibia, called as the ACL, which is going anteriorly on the tibia, and the PCL, which goes on the posterior border of the tibia, anterior cruciate ligament and the posterior cruciate ligament. ACL restricts the hyperextension, the internal rotation of the knee joint. PCL restricts the external rotation, and the movement they restrict, they're damaged by the same. And this is what you should always remember. And if you look at a repetitive force, it's called as a stress fracture, and in stress fracture, remember, you can pick up the marrow edema. The cortical breaches later. So a stress fracture will always be picked up on an MRI. So overall the investigation is MRI. Unilateral stress fracture is again an MRI. But if they talk about bilateral, do an investigation which can scan the whole body, picking up the osteoblastic activity, called as a bone scan. But if you want to pick up a malignancy in a radiological appearance, it is going to be a PET scan. It can scan the whole body, and the fluorodeoxyglucose, the deoxyglucose will be taken up by the tumor cells, which have anaerobic metabolism also, and you label it with radioactive fluorine, you can pick it up. So if you have single lesion of a metastasis, MRI, multiple PET scan. But if you have osteoblastic lesion, PET scan is quite about it, and you will be picking up in a bone scan, like the lesion of a prostate cancer, the carcinoids, or the medulloblastoma. All three of them are labeled as osteoblastic metastasis, which is very important, can be picked up on bone scan. And if I am going to find out about the investigations that become positive in cases of infection of the bone, number one, sensitive and specific, is MRI, followed by bone scan, and X-rays, which usually become positive after 24 hours, showing you a periosteal reaction in day 10, but after 24 hours, there will always be a loss of soft tissue plane. Mind you, the first change on an X-ray of osteomyelitis is loss of soft tissue plane, whereas periosteal reaction occurs in the second week of life. And then comes the bone tumors, which are usually picked up on MRI, except one, that's osteoid osteoma, because it's a cortical lesion, so that is what is picked up on CT scan. And then remember, you can do anything for a tumor, but if you have to be diagnostic, it is going to be tissue, which is diagnostic. So infection on tumor, take out a tissue, divide it into two parts, send one for culture. If it's infection, it will grow the organism. The other one goes for histopath. If it's a tumor, you can pick it up. That's how it goes. One condition in which you have a shallow acetabulum. So if this is your cup holding on to the head, this is the cup called as the acetabulum, and this is the head. And if this is shallow, your head is bound to dislocate, called as DDH, developmental dysplasia of hip, which has got a screening tool of ultrasonography, but the investigation of choice is going to be an MRI. And remember, on ultrasound in DDH, it is the alpha angle that decreases. So remember this mnemonic, AD. So alpha angle decreases in DDH and ultrasonography. And I just told you that tissue is diagnostic. You will always do a clinical radiological evaluation before doing a tissue diagnosis. The incision is along the long axis of the bone or the limb. Avoid the neurovascular status. You go through the muscle. Plan to take a round or an oval hole, never make a square, otherwise there will be stress fractures. Take it from the periphery, because in the center you have necrosis. Take it from the multiple sides. And then if you're looking at a joint, remember the mnemonic X mask. Number one investigation to look at the joint is X-rays, followed by MRI, followed by aspiration or arthroscopy. And remember, the aspiration is always done by ultrasonography. And then if you have anything that irritates a bone, it will show a periosteal reaction, which is a new bone formation. If it's a benign lesion, it will be a single layer called a solid periosteal reaction, seen in day 7 to day 10 of osteomyelitis. But if the disease is aggressive, aggressive or more chronic, you can have rays coming out called as sun ray appearance. You can have multiple layers over it called as onion peel appearance, or you can have a triangular piece underneath the periosteum called as Codman's triangle. So this is a Codman's triangle which can be seen in any malignant lesion, any chronic process, but usually osteosarcoma. Similarly, sun ray appearance, any malignant lesion, any chronic process, but usually osteosarcoma. And then onion peel appearance will look like a hazy cortex, any malignant lesion, any chronic lesion, but usually Ewing sarcoma. And this is what you should remember. And this is what is the classical feature: sun ray and Codman's triangle, osteosarcoma, but any malignant lesion, onion peel appearance, Ewing sarcoma, but can be seen malignant lesion or chronic osteomyelitis, soap bubble appearance, giant cell tumor or adamantinoma, patchy calcification. At some places it's calcified in cartilaginous tumors like chondrosarcoma and chondroblastoma, and homogeneous uniform calcification seen in bone forming tumors like osteosarcoma. And if they don't mention patchy or homogeneous, remember to choose chondrosarcoma, then chondroblastoma, then osteosarcoma in this order. And this is what you should remember: soap bubble appearance going right till the end of a bone. There is no tumor which can involve the joint except the giant, called as a giant cell tumor, which can go and invade the cartilage, because tumors, they respect the joint, they respect the cartilage, whereas the infections, they eat both. The only tumor which can involve it is GCT, and that's the only tumor which can go in the subchondral area or involve the joint surface. This is giant cell tumor. And remember the dictum: tumor of lower end radius till proved otherwise is GCT. Remember that. Coming to some question regarding investigation of malignant tumors, you will do a biopsy by transverse incision. Wrong. You will go in a vertical direction. Sample should be taken from two sides. Correct. You should do sampling before radiological appearance. Wrong. Sample should be taken from periphery, not from center. Correct. So B and D are correct. Coming to the next, a young marathon runner is participating in a marathon competition. After running for 100 meters, he develops pain in the anteromedial tibia, which was mild to start with, but increased on further running. So this is a classical case of a stress fracture, also called as shin splints, which is due to repetitive force, which is seen in military recruits or marathon runners. A 14-year-old male obese child from endo department was referred to emergency for a limp. And if there's a limp, you will get an X-mass done. So you'll do an X-ray, you do an MRI, and do an aspiration, which is done by ultrasonography. So CT scan is not carried out. The earliest radiological sign of TB spine is loss of curvature of the spine. But if loss of curvature is not given, as in this question, you will choose narrowing of the disc space. So remember, the loss of the curvature of the spine is the earliest sign of the TB spine. And what is the earliest bony change of osteomyelitis on X-rays? Mind you, in this question, they are not asking you to change. The change is loss of soft tissue plane. The bony change is a periosteal reaction, and that is why this is a key point that one should remember. Coming to infections, remember in orthopedics, the number one organism is Staphylococcus aureus, and the area affected is metaphysis. As I had already told you, infections and tumors is metaphysis. Some exceptions that you should remember: sickle cell anemia. Salmonella is the organism, but it affects the diaphysis. If they ask you metaphysis in sickle cell, think about Staph aureus. Drug abusers, Pseudomonas. Foot, Pseudomonas. Open injuries is also Staphylococcus aureus. Human bites is Eikenella, animal bites is Pasturella. Also remember that in sickle cell anemia, the Salmonella can cause multifocal osteomyelitis, can involve different areas of the body. The most common area affected in osteomyelitis is lower end of femur. In adults is the vertebral body. And if they talk about the joints, the knee is the commonest affected joint. Coming to the position that a joint can attain is in the lower limbs of Faber, which is flexion, abduction, extension of the lower limb, and that's the position in which the hip has more capacity. And the opposite of it is flexion, adduction, internal rotation. Now the causes of Faber, number one is synovial proliferation. It can be idiopathic, transient, tubercular. Number two is infection, septic, that is pus in the joint, pyogenic. It's not actually arthritis, it is pus in the joint causing Faber. Irritable band contracture seen in polio, and dislocation of the head out called as anterior dislocation. That's a rare variety. The commoner variety of dislocation, which is majority, more than 90% cases, is posterior dislocation called Fadil. And if there is a cartilage damage, the actual arthritis, it's Fadil. So remember the last line: posterior dislocation is more common than anterior dislocation. Similarly, if the joint is totally destroyed, it's called as Tom Smith arthritis. So whenever there's an infection of the limb, that is osteomyelitis, or the joint, the movement is absent. But Tom Smith arthritis is an exception. Initially the movement is absent, but then the head or the capital epiphysis of the femur gets destroyed. There is hypermobility and instability of the joint. Very commonly asked question in NEET and AIIMS. Coming to subacute variety of infection called as Brody's abscess. If subacute is not mentioned, you can take chronic. It's seen at upper end of femur and has sclerotic margin. Sclerotic margin means good immunity. So it's not seen in HIV positive. Whereas when there's a chronic infection, there will be a dead bone called as sequestrum, which is pathognomic, surrounded by a reactive bone called as involucrum. Then the draining sinuses right from the center through the involucrum called as cloacae. Chronic osteomyelitis should be handled immediately. If not, can lead to a amyloidosis and malignancies. When we look at the image, in the center, the dark, dense, white colored, dense bone is sequestrum, followed by a reactive bone called as involucrum. Sequestrum means in the cavity. And then you have the draining sinuses called as the cloacae, which are coming till the surface. And this is very pathognomic picture. You can see the upper end of humerus here. You have a cavity, the sequestered bone and the surrounding involucrum. Many a time they just show an image, or they can just ask you by labeling is sequestrum or involucrum. And then this surrounding live bone or involucrum creates a rim around the bone called as a rim sign. And when you want to remove the dead bone, there will be a point where the bleeding starts, and that's called as paprika sign. And the instruments which are shown here, you can see the bone nibbler and a bone cutter, and bone nibbler has been asked multiple times in the exams. And when you want to cover up any area of infection or trauma with a good soft tissue, there's a technique called as negative pressure wound therapy. This was asked as an image in AIIMS November 2019 this year, where they wanted to understand that are the students aware of these type of technology which are coming. And this negative pressure wound therapy, you create a pressure of -75 to -125 millimeters of mercury. It gives a good granulation tissue, but contraindicated if the infection is not controlled, if there's a necrotic tissue or is a malignancy, because this increases the proliferation. When I spoke about salmonella, I told you there can be multifocal osteomyelitis. But then if they ask you out of salmonella and one more condition, which is multifocal osteomyelitis, the answer is Seyfo syndrome. Although it's not an osteomyelitis, it's an osteitis. It's an autoimmune disorder which also has, along with ankylosing spondylitis, the HLA-B27 positivity, and it has an acronym of synovitis, acne, pustulosis, hyperosteoitis, and just like any autoimmune disorder, treated by NSAIDs, steroids, and disease-modifying drugs. They can show you a finger and they can ask you to pick up some diseases like infection of the nail bed called as paronychia, which is the commonest infection of hand, or they can involve the pulse space of finger called as phelon or whitlow, and or they can show you infection of the flexor tendon sheath, where you can have the cannibal sign, which are 4 features, which is pain on stretch, uniform swelling, flexion of the finger, and percussion along the sheath, which is the most specific cannibal sign. And remember, it is the communication between the fingers which can spread the infection. So there can be a spread of infection between the thumb and the little finger, but since the middle 3 fingers, they are separated out, they are not connected to these 2 bursas, so the infection from the little finger can involve the thumb but not the index finger. That's a rule that you should remember. And look at this image, you should not forget this image. If you have multiple draining sinus around the foot, think about mycetoma, which is the U mycetoma, the fungal mycetoma. And if you have it around the jaw, that is actinomycosis. So above the waist is bacterial cause, below the waist is fungal cause, and mycetoma is on MRI creating a dot-like circle. This is what dot in the circle sign, remember that. And 2 conditions which are painless and orthopedic, Charcot's and mycetoma. So this is what you should remember, the neuropathic joints and the mycetoma. And coming to questions, true or false in view of septic arthritis, widening of joint spaces, they are no, because it is reduced. Staph aureus is the organism, true. IND and are after culture and aspirate an antibiotic for 24 hours. And you might have to do it more aggressively. You don't have to wait in such cases. But yes, if the presentation is more than 24 hours, you usually have an operative intervention in cases of infection, but of the bone, but in the joint infection, you have to be very aggressive. So false. Kocher's criteria can be used to differentiate, is true. It is basically a composition of 4 criteria, and as they become positive, the chances of septic arthritis being very high. If the patient is not able to bear the weight, if the ESR is more than 40, if the fever is more than 38.5 degrees, and if the WBC count is more than 12,000. These are 4 criteria. From 3% in 1 positive to more than 90% in 4 positive is the sensitivity of these criteria, which can be used for differentiate. Position of the hip is farther, so septic arthritis is a Faber, so that is not possible. So there are 2 answers which you remember. This is what I discussed with you, that little finger can spread to thumb but not to index finger. This is true about tenosynovitis. Multifocal osteomyelitis, here you have both the options, SAPHO syndrome and sickle cell, and I told you that you will choose SAPHO syndrome. And in osteomyelitis of spine, the most common organism, remember, in cases of any bone in the body, the king of orthopedics is Staphylococcus aureus. Do not try to deviate from this path. Remember, this is a very, very important point. So anywhere, even spine, the organism is going to be Staph aureus. Tuberculosis. TB is always secondary in bone and joints. It comes from the lungs followed by lymph nodes. The spread is through the blood. All the infections come to the bone or the joint through the blood, hematogenous, but the picking up rate of organism is very low, so called as paucibacillary. The order of involvement is just like SRK, Shah Rukh Khan, SHK, spine, then hip, then knee. Spine involvement is also called as pot spine. Tuberculosis of shoulder is dry, called as Keri sicca. Tuberculosis of finger is called as spina ventosa. Tuberculosis usually does not produce the periosteal reaction. The only place where it can do is spina ventosa. TB involves 2 vertebrae. It is not a single vertebral disease. It involves the anterior elements in the spine. Tuberculosis of the spine will involve the vertebra and the cartilage both, the bone and the cartilage both, the vertebra and the disc both. It's according to the distribution of the mesodermal somites and the segmental artery carrying the bacteria. When you look at the presentation, the earliest presentation is pain, earliest sign is tenderness, earliest neurological sign is increased deep tendon reflex. TB, the treatment principle is rest plus ATT, and when indicated surgery. The indication of surgery in any disease of spine is 3. Bowel bladder control lost. Patient has a worsening neurological status. Patient is not improving in spite of the conservative management. Good signs: when it will improve, younger people improve better. Early disease in the first 2 years, better. Infection present, ATT will work. Active disease, better. Slow worsening of neurological status, better. Neural tissue normal on MRI, better. When you look at the outcomes of joint disorders, you can have ankylosis, which is a pathological fusion of a joint, which can be fibrous, which is painful because fibrous has F, painful has F in it, and it is seen in tuberculosis of the peripheral joints and RA. Bony fusion, which is rock solid fusion, seen in joint infection like septic arthritis, spine TB or ankylosing spondylitis. As for solid, as for septic, spine TB or ankylosing spondylitis S. And when there is a surgical fusion of a joint, it will always be bony, but it will be painless. And an example is cobra plate used for hip arthrodesis. But the trend today is to replace the joints. When I look at the upper end of femur, there is an area which has got less monocyte macrophage system called as the Babcock's triangle, which is very common area where the tubercular bacilli sit. But the commonest area where the TB hip will affect is acetabulum. TB hip stages: synovitis causing Faber, lengthening, only stage of lengthening, early arthritis, damage to the cartilage, less than 1 centimeter shortening and Fardet, flexion, adduction and rotation, late arthritis, more than 1 centimeter shortening, damage to the joint, unstable femoral head, migrating from one corner acetabulum to other, wandering acetabulum. It should be called as wandering femoral head, but a misnomer. When the fibrous fusion, fibrous ankylosis, because the spine is bony, peripheral joint is fibrous ankylosis. Remember, TB affects the acetabulum. There is earliest neurological sign in TB spine: loss of curvature. TB hip, periarticular osteopenia. Tuberculosis of knee is a chronic process. Gradual onset pain, limp in the child, flexion of the joint and synovial proliferation are the features. If you do not treat it early, it will end up into triple deformity, which is also very commonly seen in RA. So TB and RA, 2 cause of triple deformity, you must remember, which involves the posterior subluxation, external rotation and flexion. These are the components of triple deformity. Coming to the questions, assertion and reasoning. Decompression surgery is needed with a progressive deficit in port spine. True. Even after completion of ATT, there can be neurological abnormalities. True. It is not a guarantee it will recover. So assertion is true, reasoning is true, but it is not the correct explanation of assertion. Coming to next, a 30-year-old male, HIV positive, is on antiretroviral therapy. He has pain in the right hip with fever. So HIV is a very common setting in which you have tuberculosis. Along with fever, you will mark it to be TB hip. Similar question but very different. Same age, HIV, but is on antiretroviral therapy, protease inhibitors, has a pain in the hip, but there is a limitation of abduction and rotation. Whenever these two movements are limited, as I told you in the first part, that there is a loss of the hip. So there is a change in the shape, and this is not TB hip. So on protease inhibitors, the vascularity can be compromised, causing predisposition to avascular necrosis, which is the answer here. We'll talk about AVN later. I had shown you this image, bone and the x-rays. The cartilage is not picked up. So when they talk about the upper end where you'll have epiphysis or metaphysis, the tumors of epiphysis are chondroblastoma followed by GCT in this order. Metaphysis is the most common location of tumors, and osteosarcoma you should remember. And in diaphysis, remember the 3 points: osteoid osteoma, adamantinoma, but one you should learn with your heart is Ewing sarcoma. Remember that. And this is what is given here: epiphyseal chondroblastoma more than GCT. But if they mention calcification, so I told you cartilaginous tumors they calcify, so epiphyseal plus calcification, chondroblastoma. And if they talk about metaphyseal osteosarcoma and diaphyseal, 3 tumors. If at the upper end of humerus they talk about, remember, one lesion, unicameral bone cyst. Unicameral means single cavity cyst followed by chondroblastoma. Epithelial tumors, not epiphyseal. There are 2 of them. One is adamantinoma, and the other one is the ameloblastoma. That should come to your mind. And before 1985, these 2 terms were interchangeable, but now they are used independently. The epithelial tumor that involves the tibia is the adamantinoma, and the one that involves the mandible is ameloblastoma. And here comes a very, very important point. The mandible most common tumor is squamous cell carcinoma, but ameloblastoma, the most common location is mandible. This is what you should remember. So ameloblastoma will occur in mandible, but the mandible's most common tumor is SCC. It's like a love triangle. Ameloblastoma likes mandible, but mandible loves squamous cell carcinoma. And when we talk about the age of the patient, first decade, think about Ewing's. Second decade, osteosarcoma, again a love triangle. So the love triangle says the most common tumor of the first decade is Ewing's. So first decade likes Ewing's. But Ewing's maximum number of cases are seen in the second decade. So if there are 10 tumors in the first decade, maybe 9 are Ewing's. But rest 90 of Ewing's will be seen in second decade. But this most common tumor of the second decade is osteosarcoma. It's in thousands and millions. Then coming to after skeletal maturity, which is 20 to 40 years, you have a giant cell tumor going right in the joint. And after 40 years, 2 tumors, which are the commonest tumors in the bone. Metastasis, number 1 bone tumor. Multiple myeloma, number 1 primary bone tumor. So if you have a conflict between the age and part, remember the part is more important than age. So remember the epiphysis, the metaphysis, diaphysis, they will be more important than the decades that the patient suffered from. Coming to radio-resistant tumors, I will love that you remember osteosarcoma. This is a name that you should not forget. Coming to a treatment of tumors, you can do a curettage. It's just like dry mopping or jharu lagana, opening up the cavity and cleaning it out. Or if it's sticking tight, embedding into the bone, you will like to do a dry curettage. Along with that, apply a chemical treatment called as a wet curettage. This is called as an extended curettage, right? This is jharu plus pocha. So there's something more. And the most common chemical which is used for extended curettage is phenol. Not phenyl like in home, phenol. In orthopedics, it's phenol. But then your excisions, you will remove the tumor, like taking out from the center, intralesional, taking out through the margins of the tumor, that is the pseudocapsule, the marginal excision. Normal cuff of tissue all around, wide local excision, removing the entire bone called as radical excision, and which is the most common one, the wide local excision. How much margin? 3 centimeters. That is the standard margin that you take, and that's why remember the tumors. Benign tumors always operated. Cartilaginous tumors again operated because cartilaginous tumors are radio-resistant, chemo-resistant. Most common surgery in the tumors, wide local excision. Other surgeries, curettage for like unicameral bone cyst, single cavity at the upper end humerus, unicameral bone cyst. While you have extended curettage, they're using chemicals like phenol, the commonest one, or liquid nitrogen, the most effective one. And then you have 4 lesions here which is treated by extended curettage: aneurysmal bone cyst, giant cell tumor, chondroblastoma, and enchondromas on the hand that you see. So these are 4 lesions treated by extended curettage. And then if you have a malignant lesion, treat them with chemotherapy, decrease the size, decrease the vascularity, followed by a surgery with 3 centimeter margin all around, followed by subsequent chemotherapy called as neoadjuvant chemotherapy, followed by surgery, followed by adjuvant means after chemotherapy. And remember one thing, which is the dictum here: Ewing's is the most radiosensitive tumor known to mankind. It melts like snow. Even then, the treatment of Ewing's is neoadjuvant chemotherapy followed by surgery followed by adjuvant chemotherapy. This is what one should always remember. Very, very, very important. And coming to the tumor identifications, if you are looking at the upper end humerus, your mind should run in the direction of UBC, unicameral bone cyst, single cavity upper end humerus is the central lesion. And when you look at the second thing here, you will have a broken cortical piece at the bottom because it's a single cavity called as a fallen leaf sign. There's one more sign called as a trapdoor sign, which is also seen in this lesion. Coming to the second lesion, aneurysmal bone cyst, multiloculated. If you get an MRI of an aneurysmal bone cyst, it will be like a fluid level. And ABC is a metaphyseal lesion seen before skeletal maturity. And if you want to see an epiphyseal lesion before maturity, it's a cartilaginous lesion, chondroblastoma, with calcification. So also called as a Codman's tumor. It's not Codman's triangle, which is a periosteal reaction associated with malignant or chronic process like osteosarcoma. Chondroblastoma is a benign lesion right at the top of the bone in the epiphysis along with calcification. And then talks about osteochondroma. It's a bony growth with a cartilage cap. So when you will touch it, you will touch the bone and the cartilage both. When you get an X-ray, you will only see the bone because the cartilage is radiolucent. So it's large to feel small on X-rays. It's not a tumor, it's a developmental malformation. It has a malignant potential. It can change into chondrosarcoma. The risk of malignant potential is less than 1% in case of solitary lesion, more than 6% in case of multiple lesions. And then there's a tumor which has night pain relieved on taking salicylates or aspirin. This is called as osteoid osteoma in the cortex of the lesion, which has lysis and sclerosis. So both osteoblastic and osteolytic cells are seen, and remember it has a growing point called as a nidus, which is in the diaphysis. And then there are not so offending lesions which are incidentally discovered. They are like white dots on the skull called as ivory osteoma, or the compact osteoma, or a shining white also called as eburnated osteoma, and they don't require treatment. But then coming to tumors of the hand, you know the most common tumor of the hand is squamous cell carcinoma. Most common tumor of the bones of the hand is a cartilaginous tumors called as enchondroma, which is highly in cartilage in them. And there are 2 syndromes associated with them: Olliers, which is only enchondromas, Olliers syndrome. And then you have Maffucci, M for Maffucci, M for many things, that is multiple enchondromas with hemangiomas with phlebolith, which means the calcified superficial veins. So these are the 3 components. You have the phleboliths, you have the hemangiomas, and you have the enchondromas. All 3 can be featured here. And then coming to the tumor, which is the ruler of MCQ world, the giant cell tumor. That's the only tumor which can go to the joint. So if I look at the upper end of tibia, I will see a tumor going right till the joint. That's a GCT. It's seen after skeletal maturity, and it's seen right in the epiphysis. Whereas before maturity in the metaphysis is an aneurysmal bone cyst. I told you the tumor that can go to the joint, and if you have lower end radius, is GCT till proved otherwise. That's a rule, that's a dictum. This is how the X-ray will be. It will finish off the bone, thin cortex, because it loves to eat. Slow grumbling. After maturity, upper and femur, within 1.5 centimeter of the joint. So it can be till the joint, but it should be within 1.5 centimeter. So this is what lower end radius, upper end tibia, upper end femur. And then remember, The most common area is lower end femur. The third love triangle. Lower end radius loves GCT, but the GCT loves lower end femur, the commonest site for it. And coming to upper end femur. In the upper end femur, you can see the change of the shape like a stick of a shepherd called a shepherd hook deformity, which is seen in fibrous replacement of the bone called as fibrous dysplasia. And there's a syndrome with it called as McAcune-Albright syndrome, which has polyostotic fibrous dysplasia, precocious puberty, and coffee-colored spot, the coffee-colored spot called as pigmentation. If you have vertical striations in a vertebra, it's called as hemangiomas, corduroy appearance or jail bar pattern or jailhouse pattern. And if you do a CT scan of this lesion, you will see unequal sized dots called as a polka dot pattern. It's a theoretical question. And if they talk about a lysis of the sacrum, think about chordoma, which arises from the notochordal remnants, and they have the cells which have vacuoles called as physalliferous cells. When they talk about the pulsatile bone tumor, it should come to your brain. They're talking about a tumor that makes ossification called osteosarcoma. It's a cancer of the youth seen in second decade of life. Radiation induced sarcoma, radio resistant bone tumor, bone forming tumor associated with retinoblastomas. This tumor is very commonly metastasized in the lung, can cause pneumothorax. The poor prognostic factors are grade of a lesion, systemic metastasis, which are more poor than pulmonary. So if liver is there, lung is there, the patient with liver mets is the poor pulmonary metastasis. Extent of a disease, which means the stage, is also important in cases of osteosarcoma. And coming to Ewing's, remember the controversial point here, the first decade most common tumor is Ewing, but Ewing's peaks in the second decade, seen in the femur diaphysis. Osteosarcoma femur, lower end. Ewing sarcoma femur, middle. Both have pain. Most common tumor with pain, osteosarcoma. Most common tumor with night pain, osteosarcoma. Most common tumor with night pain relieved on taking salicylate, osteoma. Another tumor which has pain is Ewing sarcoma. It presents like osteomyelitis. Classical presentation of Ewing's and osteo can be like osteomyelitis. And remember the poor practice of Ewing's: relapse, chemoresistance, metastasis, increased counts, ESR, fever. And isn't it just similar to presentation of osteomyelitis? Yes, fever. So if Ewing's presents like osteomyelitis, is already a poor prognosis. So remember one thing, Ewing's cannot be graded like osteosarcoma. All Ewing's are high grade. Coming to a third malignant tumor, chondrosarcoma, which is commonly seen in pelvis. It has the best prognosis among the malignant tumors. So the best among malignant, chondrosarcoma, osteosarcoma, the worst is Ewing sarcoma. And then this is a tumor which is associated with hyperglycemia. Skulls and the lytic lesions have been shown for last 5 years in every exam. Multiple lytic lesions which are punched out are seen in multiple myeloma, which is a plasma cell tumor, which is a lytic tumor, which will never have an osteoblastic activity except for a fracture. And there can be lysis anywhere in the body, in the skull, the femur, the humerus, the vertebra, the rib cage, any bone in the body. And that's why the lytic lesion of skull are asked to you in multiple places. And the mnemonic is Melthorme, metastasis, eosinophilic granuloma, histiocytosis, tuberculosis, hyperparathyroidism, bone infections, radiotherapy, multiple myeloma, epidermoids. And if they show you punched out lesions, multiple myeloma. If they show you beveled lesions, think about eosinophilic granuloma. They have beveled sloping lesions. So they have histiocytosis and they have grooved nucleus, which is a very characteristic feature. They can show you histopath, they can discuss in theory, has been coming in last 2 aims. They can have large lesions called as the permeative lesions, again seen in histiocytosis. Or they can have dot dots like a mixed paper of salt and pepper called as salt pepper skull. So beveled lesion, permeative lesion, salt pepper skull. Salt pepper skull is a feature of hyperparathyroidism. So salt pepper skull is a feature of hyperparathyroidism. It's just not a classical lytic lesion, but it has been grouped here because unlike the classical osteoblastic lesion like cotton wool skull, which is seen in Paget's, or a large area of osteoporosis called as osteoporosis circumference, again seen in Paget's. Or they can be hair on end appearance on the skull seen in hemolytic anemia like thalassemias. So a 9-year-old boy presents with a lytic lesion in the shaft of tibia with histopathologic groove nucleus, I'll think about histiocytosis. Which of the following is a sign of metastasis? Remember, infections affect the vertebral bodies. Metastasis, they will destroy the pedicles. If one pedicle is destroyed, it's called a winking owl sign. If both are destroyed, it's called as a blind bat. So the answer here is the first one, single pedicle destruction, the winking owl sign. And then comes the next question. Most common type of fibrous dysplasia is a monostotic fibrous dysplasia involving the femur. So polyostotic was neck acute Albright syndrome. The single involvement is monostotic, and middle-aged patient presents with a lytic lesion with back pain. So I told you osteoblastic mets are prostate carcinoid and medulloblastoma. So the answer here will be renal cell carcinoma. And then again, this is a patient of Langerhans cell histiocytosis. They can show you an image, they can show you the theory part, but this is something which is very commonly asked. A patient with GCD, which of the following is false? This is a GCD, they have already mentioned, but you can see that this tumor is going right till the joint. And remember, in GCT, the treatment is extended curettage or excision, but you will never use the chemotherapy. So that is the answer here. And which other metabolic condition can cause osteomalacia? So there are tumors which are from the fibrogenic origin, and they can produce phosphotonin, which causes the phosphaturia and an osteomalacia or the weakening of the bone, which is very commonly asked. And look at this tumor, it's going right till the joint. Why did I place it in the first place? Because this is a tumor going right till the joint, but it has two options here which you should remember: osteoclastoma and giant cell tumor, which mean the same. But if I have to choose, I'll choose GCD because the more classical name. Most common tumor of hand, I told you. Most common tumor of hand is squamous cell carcinoma. Most common tumor of bones of hand is enchondroma. So the answer is squamous cell carcinoma here. 8-year-old boy, 8-year-old, first decade of life, complains and pain of swelling upper end tibia. Local temperature raised. Margins are irregular, variable consistency. Irregular margins, variable consistency means it's an aggressive lesion like a malignancy. 8-year-old, you won't think of METs because it's more than 40. GCT, you won't think because usually between 20 to 40. So you have Ewing's and osteogenic sarcoma. Ewing's, 8-year-old, Ewing's is more common. But when you look at upper end, so Ewing's occurs in the middle. So part affected is the middle, the diaphysis. Age is the first decade. Age goes towards Ewing's. Part upper end means the metaphysis. Ewing's occurs in the diaphysis. Part affected, given here is upper end, metaphysis, osteogenic sarcoma. Part is more important in age, so osteogenic sarcoma is the answer here. A very important question. And the associated genetic effects with Ewing is translocation 11-22, not 22-11. So the answer here is trisomy 8. And this is what you should remember when it comes to the bone tumors. This image we all remember. In this image, the different parts being shaded by different nerves supplying the different dermatomes. But I'll just tell you a simple way to remember. Tip of index finger is by median nerve. Tip of little finger is by ulnar nerve. Dorsum of first web space is radial nerve. So if you remember this, this will be good. It is very, very important to remember this point. Median nerve, ulnar nerve, radial nerve. That's all. You don't have to remember the entire chart. Sedans classify the nerve injuries into neuropraxia, which is a physiological block which have 100% recovery but recovers in one moment. The point is one moment. Axonotmesis is recovery from proximal to distal. This is also called as motor march. The Tinel sign is considered to be positive, which marks the recovery of the nerve at 1 mm per day and progressive. Neurodemesis is complete nerve transaction. It does not recover without a surgical intervention. Tinel sign is positive, means there is a cut nerve end, but not progressive because it doesn't recover. So it's static. Axillary nerve is damaged in shoulder dislocation, fractures of upper end of humerus and injection into deltoid. This is the area at the upper end of humerus, proximal arm, where the regimental badge is there. The army people have their badges called as regimental badge area. When we look at the area supplied by ulnar nerve, it supplies the palmar interossei and dorsal interossei. Palmar interossei due to adduction of the fingers, and dorsal abduct, pad and dab. So if you give a card to a patient, ask him to hold it between the fingers, he is able to hold it. It means the palmar interossei is functioning. If not, it means the palmar interossei gone, ulnar nerve palsy. Similarly, you give a book to a patient to be held between the thumb and palm. This is by adductor pollicis, and adduction is by the ulnar nerve. So if it is gone, the patient will not be able to hold the book. So he will not let the book go. So he will grasp it by flexing his thumb This is called as Froment sign. Similarly, if the little finger gets abducted, it's called as an Wartenberg sign. Again, the ulnar nerve. The movement of the middle finger to either side is called as abduction, because the middle finger does not have the palmar interosseous, it only has the dorsal interosseous. So it's called as abduction, and this abduction of middle finger to either side is called as Igawa test, Igawa with I. Coming to the median nerve, if you ask a patient to make a fist and there is a median nerve palsy, the first two fingers don't flex. This is called as pointing index. It's also called as the benediction attitude. It's also called as the Ochsner clasp test. Similarly, if you keep the pen above the palm and ask the patient to touch the pen, this is called as a pen test by abductor pollicis brevis. This is again for the median nerve. The median nerve is responsible for opposition. In cases of median nerve palsy, your thumb will be in the same plane as palm. The thumb is ideally anteriorly. This is called as ape thumb deformity, median nerve palsy. The branch of median nerve called as anterior interosseous nerve flexes the index finger and flexes the thumb, creating a wow sign, sign of appreciation called as Kilo-Nevin sign, which is for anterior interosseous nerve, a very, very important sign. Remember, the anterior interosseous nerve and the posterior interosseous nerve are very commonly asked in the exams. The lumbricals, they make a L in your hand, they flex the metacarpophalangeal joint and they extend the interphalangeal joint, so they make a L. When they are paralyzed, opposite of it occurs called as a claw hand. So claw hand. When you give a splint to it, this is called as knuckle bender splint. We have 4 lumbricals. The lateral 2 are supplied by the median nerve, the medial 2 by the ulnar nerve. When all are involved, it's called as a total claw hand. And when all are intact, this is what is called as a Babaji Ka Tullu by Kapil Sharma. It's a way to remember that lumbricals can make a L in your palm or hand. Knuckle bender splint is to correct the claw hand. Coming to the radial nerve. The radial nerve is involved in fractures of humerus. It is in contact with the bone at the spiral groove, but at the lower 1/3 level where it pierces the intermuscular septum and comes anterior. That is the most common level where it's involved. It's called as a Holston-Lewis sign at the lower 1/3 level. Then the radial nerve goes ahead, divides into 2 parts, the posterior interosseous nerve, which goes around the radial head, and the superficial radial nerve. The posterior interosseous nerve is a pure motor branch. So radial nerve palsy will cause a wrist drop with a sensory loss at the first web space on the dorsum, whereas posterior interosseous nerve palsy will cause a finger drop and there is no sensory loss. This is the sensory area for the radial nerve. Radial nerve palsies can occur in Saturday night or crutch palsy or honeymoon palsy, where the nerve is compressed against the bone with sustained pressure. So when you look at the radial nerve, when the radial nerve palsy is high, there is involvement of the brachioradialis. In low, brachioradialis is spared. In high and low both, there is a wrist drop, finger drop and sensory loss. So loss of wrist extension, finger extension and sensory loss on the first web space. Whereas posterior interosseous nerve palsy is a pure motor branch, only causes finger drop, whereas superficial radial nerve causes sensory loss and rarely palsy of extensor carpi radialis brevis. For radial nerve palsy wrist drop, we have something called as a Cockup's splint, which was asked in 8th November 2019. So remember, when you have an injury to a nerve, if it's a closed nerve injury, you apply a splint like a Cockup's splint for radial nerve or knuckle bender for claw hand. And when it's an open injury, you operate open, operate. That's a rule. Neuropraxias, 100% recovery. Radial nerve, the most commonly damaged nerve, has the best prognosis amongst all the nerves for recovery. When you look at the brachial plexus palsy, there are 2 types. When there is involvement of upper trunk C5 and C6, which is a common one with better prognosis, there is Erb's palsy. So flexion of elbow, abduction of shoulder, external rotation of shoulder, they are lost in Erb's palsy. So this is how he presents with, called as waiter tip deformity or policeman tip deformity. The other variety, the Klumpke's palsy, involves C8 and T1 nerve roots, and there is involvement causing claw hand plus minus Horner syndrome. It has poor prognosis as compared to Erb's palsy. When we look at the compression of a nerve in a closed space, what tops the chart is a carpal tunnel syndrome, which has got a phalanx test where you have ulta namaste, or a reverse phalanx test where you have a sita namaste. The most common cause of carpal tunnel syndrome is idiopathic. Then you have pronator syndrome. Again, there is involvement of median nerve. You have cubital tunnel syndrome, which has a U in the spelling, ulnar nerve. You have Guyon's canal syndrome with a U in the spelling, again ulnar nerve. You have thoracic outlet syndrome where C8 and T1 nerve roots are involved, T1 more commonly. And there are three tests for the same: the Adson's test, where you are abducting and hyperextending the shoulder; the Roos test, this came as a video in AIMS November 2019, again the same; or the Wright's test, again abduction and hyperextension. So these are the three tests which are done for thoracic outlet syndrome. You have one test called as Allen's test for the patency of the radial or the ulnar artery. This again came as a video in AIMS November 2019. You first press both the arteries and make a fist. When you do that, your palm will turn out to be white. Then if you release the radial artery, the circulation will come back and it will become red. It means there is a patent radial artery. Again, press it, make a fist, it will become white. Then release the ulnar artery and it will become red. It means that both the arteries are patent and there is a possibility of doing the cannulation. So identify the splint. This is a cock-up splint. Middle finger extension can be used to identify the posterior torsion nerve palsy, which causes finger drop. Radial tunnel syndrome, in which this maneuver is painful. Tennis elbow, in which this maneuver is painful, but not in motor neuropathies. A patient can't extend his wrist, so he has a wrist drop. But he has no sensory loss. Doesn't matter. If he has a wrist drop, the radial nerve is involved. So level at which the affected nerve is there. So head of radius will involve posterior trochleus nerve. It will only have a finger drop, can't have a wrist drop. Near medial epicondyle, ulnar nerve. It can have a claw hand. Cervical neck humerus, axillary nerve. It can have a deltoid or a TV's minor palsy or regimental badge sign. So the answer is spiral groove, where the radial nerve is involved. Coming to trauma, remember in ATLS protocol, it's ABC which is important. Whereas ACLS protocol, which is not important for trauma, it's a CAB. But remember, before airway, breathing, circulation, stabilize the cervical spine. Most common bone to fracture. What's a fracture? Break in the cortex. What is the surest sign of fracture? Abnormal mobility or failure to transmit the movements proximally. Crepitus is not the surest sign of fracture. Most common bone to fracture, clavicle. At birth, clavicle. In children, radius more than ulna. Most common joint to dislocate, shoulder anteriorly. In children, elbow posteriorly. Rarest to dislocate, ankle. And since ankle is the rarest joint to dislocate, it is the commonest area where the ligamentous injuries occur, anterior talofibular ligament. And on the medial side of the ankle, you will have deltoid ligament. When there is a fracture, the bone undergoes the stages of union. The stages of fracture healing are the hematoma, the blood around it, which is very vital, granulation tissue, the callus, the immature bone like a cotton. The consolidation means the stage of union and remodeling over years, which you will not be able to find out where the fracture took place, which is under the osteoclast. One of the important markers of bone formation are osteocalcin and alkaline phosphatase. They will be high when union occurs. And the marker of resorption is hydroxyproline. It will be high when there is a lysis of the bone. When the union occurs with a callus formation, it's called as a biological union or secondary healing. But when the union occurs when there is no mobility at the fracture site because callus formation requires a mobility, it's called as a primary healing or direct union. It occurs in plating, P for plating, P for primary union. Whereas secondary healing has a C, so callus is formed. When you expose the hematoma, it's called as an open fracture. When the hematoma is inside the skin, it's called as a closed fracture. For example, this is a fracture supracondylar humerus. This is the hematoma. It's a supracondylar humerus, extra-articular fracture. For this, you will take the patient to operation theatre, give anesthesia and under X-ray control without opening the fracture site, put a K-wire. So you are doing a close reduction. Whereas if the fracture is through the joint, there is hematoma, but the articular cartilage is breached. You need to open it, expose it and restore the surface. This is called as open reduction. So lateral condyle humerus, intra-articular fracture, open reduction. Supracondylar humerus, extra-articular fracture, close reduction. And close or open depends upon the hematoma. If the fracture unites within a period of 9 months, it's union. If it does not, it's non-union. Fractures undergoing non-union are femur neck, lateral condyle humerus, ulna, tibia, talus, and scaphoid. And remember, scaphoid, its most common complication is non-union. Coming to fractures undergoing malunion. So M is malunion, intertrochanteric fracture, supracondylar humerus, Colles and clavicle. And Colles fracture causes dinner fork deformity. Supracondylar humerus fracture causes cubitus varus, the distal part, that is the forearm and hand towards the midline. Whereas lateral condyle humerus non-union causes cubitus valgus, and these are spotters that come to you in the exam. If there is an open fracture, Gustlow-Anderson classification. Grade 1, wound less than 1 centimeter. Grade 2 is a wound more than 1 centimeter, no combination, no contamination. Grade 3 is a contaminated segmental fractures or farmhouse injuries or gunshot injuries. 3A has a good coverage of the bone, no coverage procedure required. 3B requires a secondary procedure like skin graft or muscle transfer. 3C is associated with a vascular injury. Treatment, debridement plus external fixator. You get a question on 3A or 3B usually. Remember, in swimming, shoulder is the most common joint damaged. At the shoulder, you have a tendon called as subscapularis, which is internal rotator, which allows you to place your hand over the lower back and you can lift it up, called as lift-off test. And when there's a damage to it, you can't lift it up. So it's an internal rotation called as a forgotten tendon of rotator cuff. Shoulder dislocation is the commonest anteriorly, 95% of dislocation are anterior. The Dugas test is inability to touch the tip of opposite shoulder. Dur gaya opposite shoulder. So this is normal. When you can't touch it, this is Dugas test. Callaway's test is increase in the circumference of the axilla. Remember the first two alphabets. Circumference of the axilla lengthens when the head is away. And when you place a ruler over the lateral epicondyle, it should touch the tip of acromion. It should be away from the acromion. If it touches both the point, the acromion and lateral epicondyle, it means the contour of the shoulder is gone and you are able to touch it. Whenever the head goes anterior, it will be below the joint and there will be abduction. So it's down and it's out. And when you want to reduce it, you have a Kocher's maneuver. So how do you do that? When the shoulder dislocates, that's the maneuver, abduction, externation, that's how it stays. So in Kocher's, you give traction, you increase the externation, you adduct it, and you do a medial rotation. Remembered by the mnemonic team: traction, externation, adduction, medial rotation. Whereas Stimson's is a gravity-assisted reduction of any joint, and Hippocrates maneuver should not be done because it applies force in the axilla with your feet. The most common complication of a shoulder dislocation is a recurrent dislocation again. And one of the common lesions associated is tear in the anterior part of the glenoid labrum called as a Bankhart's lesion, which is treated by a repair. The other lesion associated is a defect in the posterolateral aspect of the head called as a Hill-Sachs lesion. Both Bankard's and Hill-Sachs are associated with anterior dislocation. The rare variety of dislocation at the shoulder is the posterior dislocation, which is associated with electric shock or epilepsy. Here the head is at the level of the joint and it's adducted, so it's up and in. And here the head will look like an electric bulb sign, or there will be an overlap of the head on the glenoid which is normally present and it will not be here, called as empty glenoid sign. And when you have a recurrent posterior dislocation, it's associated with anteromedial defect called as a reverse Hill-Sachs. So in Hill-Sachs lesion, there is a posterolateral defect seen in anterior dislocation. In reverse Hill-Sachs, you have anteromedial defect seen in posterior dislocation, remembered by the mnemonic ramp. Coming to traumatic nerve injuries. Around the shoulder, remember it's axillary nerve. Around humerus, the radial nerve. Around the medial epicondyle is the ulnar nerve. If there is a cubitus valgus occurring slowly, it's called as tardy ulnar nerve. Elbow dislocation behind the epicondyle, medial epicondyle, the ulnar nerve. Around the head of radius is the posterior interosseous nerve. And when there is a fracture of upper end of ulna with a dislocated radial head, then the posterior interosseous nerve gets damaged. This is called as Montagia. So in Montagia, there is a dislocation of the radial head. In the wrist dislocation, it's a median nerve. Around the hip is the sciatic nerve, and around the knee is the common peroneal nerve. Now this is the Halston-Lewis sign occurring in the lower one-third of humerus. The radial nerve is getting involved because it's getting entangled in this spiral fracture. This is the Montagia, fracture of ulna with dislocated radial head, and around the radial head you have the posterior interosseous nerve going, which is damaged, causing the finger drop, only pure motor branch. And when a person has a fall on outstretched hand called as a fouche, the most common injury is the Colles fracture in a fouche. And Colles is also the most common fracture in the elderly, in the osteoporotic ladies. And when we talk about in a young man, the most common injury is a scaphoid fracture into fouche. And in a child is a supracondylar humerus, fall on outstretched hand, fouche. And when I look at the elbow, the 3-point relationship, the 3 points are the medial epicondyle, the lateral epicondyle, and tip of olecranon, and they form a triangle in 90-degree flexion of elbow. Mind you, any injury above the level of elbow will not affect the points, like supracondylar fracture humerus, maintained. Whereas in elbow dislocation, this is a sign for dislocation, the 3-point relationship is disrupted. So 3-point relationship is maintained in supracondylar humerus and disrupted in elbow dislocation. You measure it in 90-degree flexion. In extension, all the 3 points are in one line. The carrying angle, the angle between the arm and the forearm is carrying angle. It's more in females as compared to males, because in females the trochlea, the medial end of humerus, the lower end of humerus, medial part is lower, causing more valgus. Whereas carrying angle is reduced, called as cubitus varus, and carrying angle is increased, called as cubitus valgus. So varus occurs in supracondylar humerus, malunion. Valgus occurs in lateral condylar humerus, non-union. This is what I told you. Supracondylar humerus fracture causes varus, also called as a gun stock deformity. Also remember, in supracondylar fracture humerus, right, you can have two tractions which are given in older times, called the Smith traction or Dunlop traction. Nowadays you do closed reduction plus K-wire fixation, what we saw. And if there is a damage to the artery in supracondylar humerus, the brachial artery, which is the commonest artery involved in upper limb, popliteal artery is the commonest artery involved overall in the body in trauma conditions. What will be the method? Close, reduce, and look for reappearance of the pulse. Fracture lateral condylar humerus, which is treated by open reduction plus K-wire fixation, because it's an intra-articular fracture, can cause cubitus valgus, and the second complication is slow onset tardy ulnar palsy, because it goes behind the medial epicondyle, and as the limb will go into valgus, there will be stretching of the nerve. The Montagia fracture, there is a fracture of the ulna with a dislocated radial head, and the direction of the radial head classifies it into different types, like type 1, anterior dislocation of the radial head. This is the commonest. Type 2 is posterior dislocation. Type 3 is a lateral dislocation, and type 4 is the fracture of both the bones along with the dislocation. When we go further, Montagia involves the fracture of ulna. So Galeazzi involves the fracture of radius, damage to the interosseous membrane, damage to the triangular fibrocartilage complex called as TFCC at the distal radial ulnar joint and damage to the distal radial ulnar joint itself. Four things are there in Galeazzi, and Galeazzi is 3 times more common than Monteggia, and Galeazzi was a brilliant scientist who described that Galeazzi fractures have to be operated. That is why it was called as a fracture of necessity. Over time, any fracture which requires surgery was classified into it, like lateral condyle humerus, like fracture neck of femur, like Galeazzi fractures, like olecranon and patella, or any articular injury. They were all classified, but if you have to choose one fracture of necessity, that's a Galeazzi fracture. Coming to the distal radius fractures, if it's an extra-articular fracture and the distal fragment goes posteriorly, means the first metacarpal is anterior. So if the fragment displaces posteriorly, it's called as Colles. So remember the mnemonic PC, Priyanka Chopra. Posterior is Colles. And if the fracture occurs and the fragment goes anteriorly, it's called as anterior is Smith along the first metacarpal. So anterior is Smith and posterior is Colles. Remember that. These are two very, very important things. And in Colles fracture, the treatment is close reduction plus cast application. And the rule is, since the Colles fragment is in supination, lateral displacement and posterior displacement, so you apply the cast in pronation, palmar angulation, ulnar deviation, called as propaganda. And if you do not treat these components of Colles fracture, there will be a dinner fork deformity. That's how it looks like. Whereas opposite of Colles is Smith. There is a fracture with anterior displacement, and that will cause a garden spade deformity. Remember this. The most common complication of Colles is not dinner fork deformity, it is finger stiffness. The other complications of Colles are carpal tunnel syndrome, rupture of extensor pollicis longus tendon, and most importantly, we will talk about it, the Sudex dystrophy. But Colles, which is the most common complication of fracture of elderly, occurs due to Fuchs. Most common complication is the finger stiffness. If there is a traction to the elbow in a child less than 4 years of age and more than 1 year, that is between 1 to 4, the radial head subluxates out of the annular ligament. The forearm comes in pronation. This is called as pulled elbow, and the treatment is very simple. Just supinate it. It will get corrected. It also gets corrected on its own. It's a self-resolving condition. One fracture of lower end radius, which is through the joint, is called as a Barton fracture. Here it's an intra-articular fracture. Colles and Smith were extra-articular with the subluxation of the wrist. So it's an intra-articular with the joint subluxation called as volar Barton if it goes anteriorly, dorsal Barton if it goes posteriorly, and unlike Colles and Smith, which are usually treated conservatively by cast, the Barton fractures are treated by surgical intervention. Now this is how the wrist looks like, and the blood supply of the scaphoid goes from distal to proximal, and the fractures occurs at the waist, and that is why it is the proximal pole of scaphoid which undergoes avascular necrosis. There is tenderness in the anatomical snuff box in scaphoid, trapezium, and base of first metacarpal, 3 points. But most importantly, scaphoid. Scaphoid fracture, you should learn to pick up the boat-like bone fractured right at the center, the waist. The proximal pole undergoes AVN, and any AVN, avascular necrosis, the bone will look more white, dense. And then, if there is a disruption between the scaphoid and lunate, you will see a gap here, which is like a gap between the tooth of this gentleman, called as Terry Thomas or David Letterman sign. And in cases of scapholunate dissociation, you have something called as a ring sign also, which is there. Fractures of the base of first metacarpal are very commonly asked. If there is a fracture with a dislocation, it's called as Bennett's. And when there is only a fracture, comminuted fracture with no dislocation, it's called as Rolando. Remember one golden rule, both are intra-articular. If you look at the lateral view, the radius, the lunate and the capitate, they are in one line. If only the lunate comes out, this is called as lunate dislocation, and the lunate stays in, all other goes out, it's called as perilunate dislocation. Also remember one important key point. In lunate dislocation. On AP view, it looks like a pi sign, a pi of a bone. And on the lateral view, it's looked like as a spilled teacup sign, a teapot sign. When you look at the complications of the trauma, compartment syndrome is a tight cast. If there's a tight cast application, there's a disruption of the microcirculation. Compartment syndrome, the most specific sign and symptom pain, not relieved or anything. Sign, stretch pain. And if you have compartment syndrome, do a fasciotomy, release till the deep fascia, decompress the muscles, otherwise they will undergo ischemic contractions. The clinical indicator is a stretch pain, and paresthesia is an absolute indicator, clinical indicator. Normal compartment pressures are low. If the pressure is more than 30 millimeter of mercury, it's an indication, but you don't measure the pressures. So compartment syndrome, tight cast, stretch pain, pain not really doing anything. Myositis, massage. Somebody had a trauma, somebody did a massage, the movement is lost. Myositis, massage. Sympathetic overactivity, Sudex. Colles fracture, united, but then there is red hot shiny skin, osteopenia. Sudex, sympathetic overactivity after Colles fracture. Femur fracture, 48 hours, fat embolism. Somebody had a trauma, femur fracture, after a gap of 48 hours he became breathless, oxygen saturation dropping, petechiae all over the body, axillary subconjunctival. Think about fat embolism. Usually they give you fat embolism after 48 hours, but nowadays they're also giving it early. Like that occurred in NEET this year. Also remember, out of all the 4 complications, compartment syndrome, myositis, Sudex and fat embolism, it is the fat embolism which is the most grievous. So this is how Sudex looks like, red hot shiny skin, patchy osteopenia. So you can see here the telltale sign that the bone has united. That's how it looks like. So patient, known case of epilepsy. Where will the dislocation occur? Posterior, in the shoulder. Which of the following fracture is seen in patient who follow a flex wrist? Remember, flex wrist, Smith fractures. Colles is extension injury. Which is the most common sequelae of a dislocation of shoulder? Recurrent dislocation. So when we look at the spine, the curvature of the spine, we have the cervical spine which has got lordosis, thoracic spine, the kyphosis, and the lumbar lordosis. Is the lumbar spine lordosis? That comes as a question to you. And similar in the spine, you need to remember one angle. The lateral curvature of the spine with the rotation is called as scoliosis. And the edges of the top and the bottom of this curve is measured. The total curve is called as Cobb's angle, and that decides in the management of scoliosis. When we look at the trauma in the spine, we need to know some fractures like Jefferson's fracture, which is the fracture of atlas, or Hangman's fracture, which is the fracture of C2 over C3 spondylolisthesis. But if you have to choose between the one, C2 is the answer. Spondylo means vertebra, listhesis means slip of one vertebra over the other. Then you have the Clay-Shawler's fracture. It is the damage to the lower cervical spine and upper thoracic spine, so C7 and D1. And if you have to choose C7, because C for Clay-Shawler, C for C7. Sometimes in children, because of the flexibility of the spine, there is no damage to the vertebra, but the neural tissues can be disrupted. This is called a spinal cord injury without obvious radiological abnormality. The word radiological here means the X-rays, not the MRI, because MRI will obviously show you changes. The stability of the hip is assessed by the Trendelenburg test, and your hip is, along with the acetabulum, the head of femur, the trochanters, and the intact femur neck, can maintain your body weight on one limb, will not allow the drop of the pelvis on the opposite side when you're standing on one limb. So you're standing on the left side, the right side stays straight. But if the left side, the nerve supply, the liver arm, or the muscles are paralyzed or affected, then the opposite side drops. It's called as a drop. That is, drop of the opposite side of pelvis is called as positive. And when both the sides is positive, bilateral disease is called as a waddling gait, because the duck waddles, that's how it walks, called as a waddling gait. Thomas test, and it's for the hip flexion deformities. And if you look at the upper end femur, the bony trabeculae clearly shows that the form is because of function. So weight bearing axis, there is more density of the trabeculae. This is the weight bearing line, and the trabeculae between the acetabulum, the head and the neck are aligned, and when there is a disruption at the neck, the rotation of the head occurs and these trabeculae can be disrupted. This is called as fracture neck femur disruption. And then you also can have a fracture, the intertrochanteric area, which is extracapsular. When I look at the neck femur fracture, is classified according to trabeculae. When there is only a valgus at between the head and the neck trabeculae, it's called as type 1, garden stage 1, which is an incomplete fracture, but there's a valgus. So the trabeculae are not aligned. Stage 2 is a complete fracture, but there is no displacement, so all the trabeculae are aligned. Stage 3, the head and the neck, they lose their contact and there's a rotational ligament, so all the trabeculae are disrupted. So all three malaligned. It's a partial displacement. Stage 4 is completely displaced, so head aligns with the acetabulum, but the neck malaligned. 1 and 2 are clubbed together, 3 and 4 together, because that's how the prognosis is. When we look at Powell's classification of neck femur, it is the angle that the fracture makes with the horizontal, more the vertical, more the displacement, more the horizontal, more the compression. So the prognosis depends upon the verticality, 30 degree, 30 to 50 and more than 50. So vertical fractures have poor risk. And as the blood supply goes from the distal to proximal, so the more the proximal the fracture, the worse the prognosis. So subcapital fractures have poor prognosis in the transcervical, means between the neck, which is poorer than the intertrochanteric areas. So when I look at the neck femur and intertrochanteric, also called extracapsular fracture, the intracapsular fractures have less age. They usually present around 60. Extracapsular usually present around 80. They have less pain, they have less shortening and less externodation, whereas intertrochanteric fractures have more externodation. The lateral border of the foot touches the bed and they have marked shortening. So all the clinical features are more in extracapsular. So extra, everything is extra. And when we look at the treatment of extracapsular fracture is simple. You put a nail along with a screw called as proximal femoral nail, now the preferred treatment, or you can also put a dynamic hip screw. Screw along with a plate, and as the bone unites, it slides on. Whereas the neck femur is also called an unsolved fracture in patients less than 65 years of age, and the fracture less than 3 weeks, you just put the screws. If the fracture in the same age group is more than 3 weeks, you put something more, because these fractures are known not to unite, like a bone graft or an osteotomy, to make the fracture line more horizontal. But if the age is 65 or more, you replace half the joint, called as hemiarthroplasty. But any age, if the cartilage is getting damaged along with neck femur, you do a total hip replacement. Right? The most common complication of a fracture neck femur is avascular necrosis, followed by non-union. When I look at this image, this is a gallows traction used for fracture shaft femur less than 2 years of age. And this is a Thomas splint, which was initially described for TB knee by Thomas for his own wife. But now this Thomas splint is being used to immobilize the lower limbs. When I look at the fracture shaft femur, so if you look at the age group less than 5 years, you usually treat it with hip spica. So spica is any cast that goes around the spine. And if it is 5 to 10 years, you do titanium nails. And if the age is more than 10 years, you put a intramedullary rod with screws called as interlock nailing. And so less than 2 years, gallows is an option, but the preferred is spica. So when I look at the hip joint, this is an image which tells you the different injuries around the hip. So hip flexion deformity is by Thomas test, image-based question. When there is shortening and external rotation of the lower limb, that means the neck femur fracture has occurred. When there is flexion, abduction, external at the hip, there is anterior dislocation. And when there is flexion, adduction, internal at the hip, so adduction and internal at the hip, there is posterior dislocation. And Fadir of flexion, adduction, internal is an image that is coming next to you, very common. So this is Faber, flexion, abduction, external of the lower limb, anterior dislocation. In anterior dislocation, whether it's the shoulder or the hip, the head will be down and the limb will be out. So the head will be below the joint and the limb will be out. So it's called as down and out. And in anterior dislocations, upper limb, lower limb, there's a lengthening. Whereas in posterior dislocation, it's opposite. So if you're going in a high-speed vehicle and there's a sudden brake, sudden halt, and your knees, they go and collide against the dashboard in the front, the force along the shaft can take your head out, called a posterior dislocation, also called dashboard injury. But if the force goes around the knee, it injures the posterior element on the upper end of tibia, posterior cruciate ligament. So if dashboard injury does not mention the posterior dislocation of hip, you can choose the PCL avulsion. Either of them is accepted as an answer. And when there's a posterior dislocation, there's a flexion, reduction, and rotation. There's a shortening, and in posterior dislocations, as a shoulder or the hip, the head is at the level of the joint and adducted. The femoral artery pulsations, they are felt against the head of femur, and when they are felt against the head of femur, that's called as vascular sign of Naruth. And when the femoral artery pulsations, when the artery goes there and the head is not there, it's gone posterior, you will not feel it. So vascular sign of Naruth is positive. Positive means posterior dislocation. It's a controversy, but you should remember positive in posterior dislocation. And when we look at the angles in orthopedic, I told you Cobb's angle for scoliosis, lateral curvature of spine. Then you have Bowler's angle and angle of Gissane around the calcaneum. Bowler's angle, it decreases with fractures of calcaneum. Bowler's lowers. An angle of Gissane, it increases in the fractures of calcaneum. Gissane gains. Q angle is measured around the knee joint. It's an angle of the pull of quadriceps, and it's more in females, but as it increases the chances of patellar subluxation or dislocation. Coming to the cast and the splints, hanging cast, H for hanging, H for humerus, it's for fracture shaft of humerus. U slab is again for humerus. Cylinder cast is for the fractures of patella. PTB is for the fractures of tibia. Glass holding cast, you align the radius and the thumb is for the scaphoid. Handshaking cast is for Colles propaganda. Dunlop traction and Smith traction are for supracondylar humerus fracture. So remember, Smith is not for Smith fracture. So Smith traction is for supracondylar humerus, and figure of 8 bandage, I think this image is going to come to you, is for the most common fracture that occurs, and that's called a clavicle. The mallet finger is an avulsion of extensor tendon from the distal phalanx. It is one of the most commonly asked MCQs. And this is a splint given to treat it for 6 to 8 weeks. Then you have Bola-Brown splint, which can be used for femur, knee, or tibia, and the direction of the pull is along the pulleys. They have Russell traction, which was initially described as skin traction, but now is a skeletal traction, which is for the hip fractures, or you can have the Agnes-Hunt traction for the flexion deformities of the hip. You have Milwaukee brace, the Boston brace, which is for scoliosis, and coming to the important fractures, the eponymous fractures, the named fractures, which is always asked in every exam. So if you ask me, the arthritis, the nerve injuries, and the upper limb, these are 3 important things in orthopedics. And Jefferson's fracture is the first fracture as you go cranial to caudal. So it is the fracture of the atlas. Hangman's, C2. You remember it like this, H2. Then you have the nightstick fracture, which is an isolated fracture of the ulna. It's because of the direct blow on the ulna. Then you have the Schoffer's fracture, an intra-articular fracture because of the radial styloid, a very commonly asked MCQ. Colles, I told you, is an extra-articular fracture with a posterior displacement. So posterior is Colles. Then you have the bucket handle injury. Now the bucket handle injury means if there is an anterior disruption of the pelvis on the right side, there is a posterior disruption on the left side. So that's how, like a bucket handle, it sways down. This is bucket handle injury. Now the open book, the anterior structures open up hinging on the posterior side, called as an open book. Both are the type B injuries. So they are instabilities occurring in the pelvis, which are type B injuries. And then you have this is open book, and then you have the Melgagnez injury, where the disruption anterior and posterior on the pelvis occurs on the same side. So that's the Melgagnez injury, which came as an image in the JIPMER. Straddle fracture is a superior pubic rami bilaterally, and the pylon fracture, again it came as a question in May 2019. Is an intra-articular fracture of the lower end of tibia disrupting the joint. Aviator's fracture is a fracture involving the neck of the talus. Then you have Jones fracture, which is involving the base of the 5th metatarsal, and pseudo-Jones involving the tip of the fifth metatarsal, the insertion. So it's more proximal. That's pseudozones. And then you have the proximal humerus fractures, which are classified by Need's classification into 4 parts: the head of humerus, the greater tuberosity, the lesser tuberosity, and the shaft, and then the supracondylar fracture humerus, which usually goes posteriorly and medially, called as posteromedial displacement. And since it goes posteriorly, it's called as an extension type of injury. And then you have the Monteggia, fracture of the ulna with the dislocated radial head. Then you have the Galeazzi, fracture of the radius with the disruption of the distal radioulnar joint. Then you have the Boxer's fracture, where there is a fracture of the neck of the fifth metacarpal. Then you have the bumper fracture. Again, Schoffer's and bumpers are 2 fractures very commonly asked. Fracture of the lateral tibial plateau. Then you have the Cotton's fracture, involvement of the posterior malleus, the medial malleus, and the lateral malleus. So CT, trimallear fracture, 3 malleus. You have the Potts fracture, the lateral malleus, and the medial fracture. So it is the bimallear fractures. And then you have the Chopard's fracture. There is a displacement of the intertarsal area. CIT, sit. Chopard's is intertarsal, and Lisfranc's is a disruption of the tarso-metatarsal area. They are anatomical areas, Chopard's and Lisfranc's, very commonly asked. And now we remember this March fracture, a controversial king, the neck of the second or third metatarsal. It's not the shaft, it's the neck that you should remember. Runner's fracture, very commonly asked, is fracture of the lower part of the fibula. So this is the Need's classification. Dennis has classified the columns of the spine into 3 parts. The anterior part of the vertebral body in the disc and the anterior longitudinal ligament is the anterior column. The posterior part of the vertebral body, the disc and the posterior longitudinal is the middle column. And all the other posterior structure, the pedicle, lamina, the transfer process, and the spinous process is the posterior column. So if you have involvement of 2 out of 3 columns, it's an unstable injury. When you are treating the trauma, remember the tension band principle. When you have a fracture, the muscle pull will pull it away, and you need to hold them together. So conversion of distraction into compression is tension band principle. You need to approximate that. You can put a wire or a plate on which surface? The convex surface. Why the convex surface? Because the muscle acts on the convex surface. That's called as a tension surface. So tension band principle, tension band principle. Tension principle, apply the force to compress it. This is called as TBW, done for olecranon, the patella, the image here that commonly asked, or medial malleus. Open injuries, Gustlow classification we had done, external fixators. The plates which are done now for osteoporotic injuries, the metaphyseal area, or non-unions or weak bones, are called as a locking plates. The advantage of a locking plate: the screw heads have got threads, the holes have threads, they lock to each other. So locking plates are the plates which are being used now. You can get an image on the locking screw or locking plate. These are different types of screw: the normal cortical screw, the canceller screws, which are that have the threads at distal space, or the locking screws which have threads on the head too. An osteotome used to cut the bone, curette to clean it up, mop it up, bone cutter to make good bone grafts, bone nibbler to clean the cavity or sharpen the bone edges. These are the bone holding forceps and the plate holding forceps. So this is a bone holding forceps. What will hold the bone which will have teeth? Bone holding forceps, bone holding forceps. And if you have a smooth surface on one side, it's a bone plate holding forceps. Both the bone holding forceps and the bone plate holding forceps has come in the exam, and also the nibblers have come in the exam. This is a type of an external fixator called as a rail fixator, and if you are looking for lengthening, you can use a rail fixator or an Ilizarov external fixator. Rail fixator came as a spotter in 8th November 19 exam. So this is what angle? Cobb's angle to measure the scoliosis. When you have the fusion of the vertebrae congenitally, that's called as congenital scoliosis according to lateral deviation. Back-to-back Ames and NEET exam. All are true regarding Jefferson's fracture, except remember, upper cervical spine has a lot of space for the neural tissues. That is why C1, C2 injuries rarely have neural deficit. So they don't have neural deficit in Jefferson's fracture. It is a disruption of the arch, involves the atlas, X-rays can be normal. Which of the following are true with respect to the intertrochanteric fracture? More common in males than females. 1 year mortality rate is 20 to 30%. This is correct. more commonly associated with non-union, it's not correct. So C is not correct. So look at the options where C is not there. So you have to choose the answer C, B and D correct, because B is correct and D is correct. If you operate early, you can reduce the mortality. Coming to next, a child brought to emergency with multiple injury, femur fracture, he is dyspneic. Now, it is an emergency situation. In this patient, the answer was fat embolism, but it was early than 48 hours. Normally, fat embolism occurs in femur fracture after 48 hours, but rarely they give you a presentation here. Now, this is a bone plate holding forceps, which will hold the bone and the plate. And this is a bone nibbler, which is very, very important, that again came in the AIIMS exam. March fracture involves the neck. This is what you should remember. When you look at a spine injury, initial injury, there is a total areflexia. No motor, no sensory symptom, no Barber bladder control, called a spinal shock. This gets over. There is a return of bulbocavernosus, end of spinal shock. In the lower part of the spine, where the nerve roots are there and terminal spinal cord is there, if you have a symmetrical damage with Barber bladder involvement, it's called as conus medullaris. And if you have asymmetrical involvement, it's called as the cauda equina syndrome. So the difference is, in cauda equina only the right side can be affected, whereas conus medullaris will usually have equal involvement of both the right and the left lower limb. These three terms are very importantly asked. Rarely all the three will be a question in the exam. So joint disorders are very, very important, because in central exams you will always have lots of questions coming from it. Remember one thing, that if you point your finger towards somebody and the two joints that points towards him, these two joints are involved in OA, because that's how you say OA. And then the two joints in the finger which are towards you are RA, means calling towards you, RA. So MCP and PIP involved in RA, and PIP and DIP are involved in OA. So OA does not involve the MCP, it also does not involve the wrist. Whereas OA involves the base of the first metacarpal, carpometacarpal joint. This is what you should remember. This is what I just said. OA involvement in the DIP will be Hubbard nodes, in the PIP will be Bouchard nodes, and first carpometacarpal is the characteristic joint involved. Whenever they will show you OA, they will show you the front view. RA, they will show you the side view. That's a rule. When you have osteoarthritis of the knee, remember it's the medial compartment which is more commonly involved. And if you remember, we have done it earlier, that there is an O formation. This O formation means genu varum bilaterally, OA. And the most commonly involved muscle is quadriceps, and the most common component of quadriceps is vastus medialis. And if you want to go further, the fibers are obliquus, vastus medialis obliquus. When I am treating OA knee, the initial treatment is conservative with glucosamines or physiotherapy and medicines. If it does not resolve and the patient has limitation of activities of daily living, in a young patient, correct the deformity up to 20 degrees by high table osteotomy. In a patient who's more than 60, do a knee replacement, which will correct your deformities, will allow good movement, good proprioception. Sometimes the patella rubs against the femur upper end on extension, called as patellar clunk syndrome, but it's a rare complication to even be treated arthroscopically. Now, this is what I spoke about. In RA, you have two criteria. You have 1987 and 2010 criteria. Old is gold. It has 7 points, and 1987 7 points, and 4 out of 7 is RA. So you have morning stiffness more than 1 hour. You have arthritis of 3 or more out of 14 areas, which is PIP, MCP, wrist, elbow, knee, ankle, MTP. So bilaterally, so 14 joints, 3 out of 14. You have bilateral hand involvement. You have symmetrical involvement. You have presence of rheumatoid nodules, which is the most specific pathognomic, serum rheumatoid factor positivity or X-ray changes. Out of these 7, if 4 are there, this is RA. Whereas in 2010 criteria, 10. So there's a 10. Total score is 10. More than equal to 6 is RA. Number 1 is more the joints involved, more the points. So up to 10 joints involved, 5 points. High rheumatoid factor anti-CCP more than 3 times, 3 points. ESR and CRP, C-reactive protein high, 1 point. More than 6 weeks, 1.5 and 3, 8 and 1, 9 and 1, 10. More than or equal to 6 is RA. In RA patients, you should be knowing how to identify the swank neck deformity, flexion of DIP, extension of hyperextension of PIP. This is swan neck. When there is only flexion of DIP, that is mallet finger, avulsion of extensor tendon. Opposite of swan neck is the Boutonniere deformity. There is extension of DIP, flexion of PIP, and it's because of disruption of the extensor tendon. Whereas in swan neck, there is a disruption or weakening of the flexor tendons. You have ulnar deviation of fingers, which are very common. There is a subluxation, ulnar deviation of finger, and radial deviation of wrist. So the wrist will go radial and the fingers will go ulnar. That's very common in RA. Coming further, they can show you the X-rays of hand where they can show you a pencil and cup deformity, psoriasis. They can show you resorption of terminal tuft of phalanges, scleroderma, acroosteolysis. Or they can show you totally destroyed hand seen in psoriasis or RA if you have to answer one math RA. Whereas when it comes to the axial skeleton, if they show you sacroiliitis, think about a condition which is HLA-B27 positive. Yes, it's ankylosing spondylitis, low backache in a young man with reduced chest expansion, hands paired, ankles paired is ankylosing spondylitis. This is so commonly asked. They have fusion of the entire vertebra called as squaring of the vertebra, bamboo spine. They have calcification along the interspinous and supraspinous ligaments called as a dagger sign, which is an inverted knife. Then along with these calcification, there is a calcification along the facet joints. It's called as a trolley track sign. Mind you, tuberculosis involves the anterior structures more commonly. The rarest involved in TB is facet joints. So facet joints, remember, at two places, trolley track sign in ankylosing spondylitis, and rarest involved in tuberculosis of spine. And then you can have the shiny corner of the Romanus sign, sclerosis at the edge of the vertebra. They're all the features of ankylosing spondylitis. And then if you have disc calcification, intervertebral disc calcification, it should come to your main, you're dealing with alkaptonuria or ochronosis. Spotter. The urine turns black on standing. This line will be there along with this question. Inflamed great toe with erosions of the soft tissues and the bones is gout. Whereas calcification of the meniscus called as chondrocalcinosis is pseudogout. In gout you have uric acid crystals. In pseudogout you have calcium pyrophosphate crystals. And when you look at the gout, the great toe, there's a hanging bony edges. This is called as a Martel sign. They punched out or rat bite erosions around the joints. This is feature of gout. Because this is the area which is under maximum stress of the body, the great toe, that's why it's involved in gout. And then, if the joints are totally destroyed, but there is no pain to the patient, that's Charcot's, called as neuropathic joint, there is loss of proprioceptive fibers. And when there is a widened intercondylar notch, this is a characteristic feature of hemophilia, which is periarticular osteopenia all around, tall epiphysis, the patella, it looks squared, but the important point is widened notch. It's also seen in tuberculosis and juvenile rheumatoid arthritis, the widened notch, but characteristic is hemophilia. And when you have multiple loose bodies all over, that's called as synovial chondromatosis. This is the most common cause of multiple loose bodies. But the most common cause of a loose bodies is osteoarthritis. Most common joint where you have a loose bodies is knee joint. So theme and focus type of questions are being asked in AIMS now. They'll give you multiple options and then you have to choose along the theme. So the options were ankylosing spondylitis, RA, gout, pseudogout, psoriasis, reactive arthritis. 6-year-old man, dull back pain for 2 months, difficulty in sitting, standing up. There is fixed SI joints. You will think of AS. Irrespective of age, if sacroiliitis is talked about, think about ankylosing spondylitis. Middle-aged male with acute onset right knee fusion with pain, he says recurrent episodes. Remember, gout will have recurrent episodes. So this is ankylosing spondylitis and this is gout. This is what you should remember. And now a patient present with knee pain, aspiration, WBC is high, viscosity is normal. So when you have normal viscosity, think about OA because most of the disease will cause reduced viscosity. And then more specific for diagnosis of ankylosing spondylitis, we have spoken this, sacroiliitis. HLA-B27 is not specific. Although it's present in more than 90% cases, but sacroiliitis is the most specific. Now, if you look at this child and you have beating of the costochondral junction, you will think about, this is called as rosary. If it is sharp, tender, scurvy, scorbutic rosary. Like round, smooth, non-tender, rachitic rosary. R for rickets, rachitic round. S for scurvy, sharp. Now, if you look at this in a child, if you have O or R, it means it's a metabolic disorder, rickets. In rickets, there is widening. It's a mineralization disorder. So the zone of mineralization is affected, zone of calcification. And the bones, they have cup in the shape. They have splaying and they have flaring. So the bony edges, they flare out. They have splaying, broaden out, and they have cup shapes, cupping, splaying, and flaring. So when you look at rickets and you give calcium vitamin D to the patient, you will see the sign of healing, the white line of Frankel. This white line of Frankel indicates is getting treated. Whereas B and C, B is active rickets, C is healing rickets. And when I look at rickets, broadening, widening. So wrist is usually rickets, but at the knee, sometimes they talk about scurvy, sometimes rickets. So scurvy, Wimberger ring sign, sclerotic margins of epiphysis. Remember the word sclerotic. So in scurvy, sclerotic margin of epiphysis is called as Wimberger ring sign. A synonymous Wimberger corner sign is seen in metaphyseal defect in syphilis. Now this is scurvy, widening rickets, whitening scurvy. So in scurvy you have, this is called as the Wimberger ring sign. And then white line of Frankel is always seen in scurvy. What is white line of Frankel? White line at the metaphysis. So rickets, widening, scurvy, whitening, all around is white. This is what you should remember. And then if there's a bone softening disorder like rickets or osteomalacia, then the bone will give up. There's a fatigue fracture, insufficiency fracture, and that is called as pseudo fracture because it's only because of pulsations of the artery, indentation of the cortex, not a breach of cortex. This is a fracture, also called as Ambausen zone or milkman fracture or loser zone, after the man who described it, Emil Loser. Treatment is just wait. Causes osteomalacia, rickets, hyperparathyroidism or neurofibromatosis. And this is osteomalacia. You can look at that. The reduced neck shaft angle, the triangular pelvis, the triradiate pelvis, and so many pseudo fractures which have healed. So I just spoke about a bone softening disorder called as hyperparathyroidism. Our teeth have got lining called as lamina dura. And when there is a resorption of the lining, it's called as loss of lamina dura. It is seen in hyperparathyroidism, which will cause ... on the skull, called as salt pepper skull, or because the PTH acts on the osteoblast also, so you can be having sclerotic and lytic phases called as rotting fence post appearance. You remember as a child, we used to draw the fence post called as rotting fence post appearance. And they also have lytic cavities filled with blood, and the blood degradation product gives it a brown color called as a brown tumor. Coming to the ossification defects, you have two types of ossification, the end-chondral ossification and the membranous ossification. So end-chondral ossification, there's a cartilage base over which you ossify, and if it's a defect in that, it's called as achondroplasia. The patient will have short height. You know, the trunk size is normal, but the limbs are short. They're very intelligent people. They're happy people, just like Down syndrome or Angelman syndrome. But they have trident or starfish hand. This is a trident hand. There's a gap between the middle and the ring finger. And you know, many people can't do it. It's also an easy way to remember the sensory supply of hand. This is C6 supplying the thumb, C7 the index and middle finger, C8 the ring and little finger. And then you have the starfish hand where all the fingers are equal. They can have broadened pelvis called a champagne glass pelvis, or they can have the bullet shaped vertebra. So these are the features of the achondroplasia. This is trident hand. So I just told you C6, C7, C8. This is the sensory supply to remember. Just a way to remember. This is all fingers equal. Starfish hand. And when you have intramedullary ossification defect, cleido means clavicle, cranial means skull, they are defective. And when you don't have clavicle, your shoulders can meet in the midline. This is called as cleidocranial disorder. Shoulders can meet, it can come as a spotter. Your osteoclasts are important markers for bone. They do remodeling. And when the osteoclast is defective, there can be two disorders, osteopetrosis or Paget's. Paget's has multifactorial cause, so I've kept it second. In osteopetrosis, there's no marrow. Bones will look white, called as marble bone disease. No marrow, so pancytopenia. Anemia. And then, because of anemia, pancytopenia, secondary hematopoiesis, hepatosplenomegaly. The cranial nerves are narrowed down. The second nerve, the seventh nerve, and the eighth nerve are compressed. And this is treated by bone marrow transplant, which is given intravenous. The bones don't unite normally in these cases. Whereas in Paget's, you have osteoblastic and lytic phases. It's increased turnover, more formation, more resorption. You can have sclerotic margins of the vertebra called as picture frame, or you can have the entire vertebra being white ivory vertebra, or you can have a cotton wool skull in the sclerotic phase, or which causes increase in the head size, or you can have an osteoporosis circumscripta in the lytic phase, or you can have a shatter sign where it looks like as if more sclerosis is occurring and as if the hanging cap somebody is wearing. And then you will have thickened pelvic brim called as the brim sign. There can be lysis along the cortex called as blade of grass or flame appearance. These are all the features of Paget's. When you compare the bone quality, there is a ratio between the yellow and the red area. The red area is an unmineralized matrix and the yellow is a mineralized bone. When the amount of the bone goes down, the ratio maintained is osteoporosis. Calcium phosphate ALP levels are normal. But when the red area goes broad, that's osteomalacia or rickets. There is fall in the calcium, fall in the phosphate, high ALP. That's what the metabolic disorders will cause. In osteoporosis, you can have fractures of the vertebra, hip or the choles. And the bone mineral density of a patient, which is measured by the DEXA scan, should be done in females more than 65, in males above 70, is reduced. So bone mineral density 0 to -1 is normal, -1 to -2.5 is osteopenia, and less than -2.5 is osteoporosis. And osteoporosis, the fracture is severe osteoporosis. And when the entire vertebrae are involved, it will give you an appearance like this called as codfish vertebra, which is seen in osteoporosis, can be seen in osteomalacia as well, but characteristic of osteoporosis. If you have crumpled skeleton, the entire skeleton, you're dealing with collagen 1 defect called as osteogenesis imperfecta, the skeleton looks white. Compare it to this skeleton, which is also white, but the shape of the bone is maintained, seen in bone osteopetrosis defect, osteoclast defect, where the marrow is not there. And then we talk about the osteogenesis imperfecta. Remember the blue sclera, it can come to you as an image. When I look at the vertebrae, then you have alternate bands in the vertebra. When there is an alternate band in the vertebra of light and dark bone, that's called as rugger jersey spine. When you have ivory vertebra or picture frame vertebra, that's Paget's. When you have bamboo spine, that's ankylosing spondylitis. When you have codfish vertebra, that's osteoporosis. And when you have bullet-shaped vertebra, that's achondroplasia. So all the vertebrae together. And then you have increased density of the bone, like malorhistosis, which is candle dripping bone disease, or osteopoikilosis, which is spotted bone disease, or osteopathia striata, which is a striated bone disease, which are incidental discoveries. Which drug is the first line for postmenopausal osteoporosis? Bisphosphonates, because of their efficacy. What is the likely diagnosis here? Coxa vara, reduced neck shaft angle. Paget's affects what disease? It occurs more than 50 years. So if you count on the fingers, it will affect 6 decades onwards. So the answer is 7 decades. This is very commonly wrongly given in your books. Please correct that. Coming to the next phase, Chopard's amputation is an amputation involving the intertarsal area. Chopard's dislocation, intertarsal area. Lisfranc's amputation, tarsometatarsal area. Lisfranc dislocation, tarsometatarsal area. So they are anatomical terms. When I look at the knee joint, when I take my leg in, I am testing for the lateral structures called as lateral collateral ligament. So the varus stress, lateral collateral ligament is tested. The valgus test, the medial collateral ligament is tested. So when you're doing the valgus, means taking the leg out, you are testing for the medial collateral ligament. Dial test, the posterolateral corner in the knee, which is a very, very important corner. If it is damaged, the prognosis of the knee is very poor. Now pivot shift test, anterolateral corner, where mainly ACL is there, and posterolateral corner mainly PCL is there. And when I look at ACL and PCL, we saw this when we were doing imaging starting. ACL restricts hyperextended interrotation and it goes anteriorly on the tibia, whereas PCL goes on the posterior margin of the tibia. But both come from the posterior aspect of the femur in the sagittal view on the MRI. And PCL is the most posterior structure on upper end tibia. That is why when the dashboard injury affects the tibia, it is the PCL which is the worst. Right? So PCL restricts externalization, ACL restricts hyperextended interrotation. And when there is an ACL injury, sometimes there can be a chipping of the lateral tibial plateau called as a Seagan's fracture, which is a telltale sign this patient has an ACL injury. ACL injury, when you assess in 90-degree flexion, it's called as an anterior draw test. When you do it in 20 degrees, it's called as a Lachman test, which is more specific. And you can remember it like this: LAC, the first three alphabets is ACL. So ACL, Lachman test. So ACL has two parts: the anteromedial part, which provides flexion stability, and the posterolateral parts, which provide the extension stability. And it's the posterolateral part providing extension stability, which is very commonly asked in your exams. And then if you look at an athlete, they can be damaged to three structures. MAM is dangerous: MCL, ACL, and medial meniscus. So there is a damage to medial collateral ligament, anterior cruciate ligament, and the medial meniscus. This is O'Donoghue triad, and the prognosis is not good. Meniscus are the shock absorber, the cushions. So you have the Apley grinding test, grinding the femur and tibia together, or the McMurray's test for the same. You have the mnemonic MATE, McMurray's test, the Apley's grinding test, the Thessalay test, and the Agace test. These are the four tests which you have for the meniscus. The blood supply of the meniscus comes from out to in. So the peripheral 1/3, which is vascular, can be repaired, whereas the inner 2/3, which does not have a blood supply, needs to be excised if it is coming in between the joint, causing a locking. Locking means inability to extend the knee. This is called as the pathological locking. When you look at the spine and you look at the MRI, this is what is a vertebra, a disc, and the disc has come out. This is called as prolapsed disc. And a prolapsed disc will usually compress the neural structures, will present with a backache going down the limb. An MRI can pick it up. You can see here that the T2 image will show water as white. So water is white on T2, which you can pick it up here. So this is a T2 image on both the sides. And then remember these myotomes, you will be asked them. C5 is shoulder abduction and elbow flexion. C6 is wrist extension. C7 is elbow extension. C8 is finger flexion. T1 is intrinsic muscle of hand. And you remember the sensory supply? C6 is thumb. C7 is index and middle finger. C8 is ring and little finger. This is what you should remember, the trident hand. And when you look at the lower limb, L2 is hip flexion. L3 is knee extension. L4 is ankle dorsiflexion, but what you need to remember, L5 is extension of the tongue, called as extensalis longus, and S1 is flexalis longus. Why did I ask you to remember L5? Because it's the most common nerve compressed. Why? Because the most common disc prolapse described is L4, L5. And the disc will always compress the lower nerve root. So L4, L5 disc will compress the L5 nerve root as a rule. And we look at the dermatomes, L4 supplies the medial aspect of leg and foot. L5 the lateral aspect of leg, dorsum of foot and great toe all around, and is the S1 which supplies the sole and the little toe. So these are the important dermatomes that you should remember, but L5 happens to be the most important. And when you have any compression anywhere, whether it's a compression neuropathy or a disc prolapse, which is also a compression neuropathy, the treatment is plan A. Plan A means rest plus NSAIDs. If not relieved, local steroids, not oral, local steroid, if not surgery. And what are the surgery you can do? You can make a hole in the lamina, remove the lamina or the half lamina. So these are the ways that you can remove the disc. You can just make a small hole in the lamina, or you can remove the entire lamina or the half lamina. Right. When you look at the spine lateral view, you see a dog. And the neck of the dog is made by an area called as interarticularis. Why? Because the ear of the dog is the superior articular process, the front leg of the dog is the inferior articular process, in between is the neck called as an area interarticularis, and all the force in the spine, when you dance, you jump, goes to the area, the neck of the dog, and it breaks. The vertebra is called as spondylo, break is called as lysis. Combination is called as spondylolysis. So break in the neck of the dog, or dog with a collar in the neck, most commonly occurs at L5 vertebra. And when the neck breaks, the head falls. Slipping of one vertebra over the other, called as spondylolisthesis. Beheaded dog, also called as beheaded Scottish Terrier sign between the L5 and S1 vertebra. When you have a ball coming and hitting your thumb, it can do a radial deviation of thumb, and the ulnar collateral ligament of the thumb can be injured, called as the gamekeeper's thumb. This is the most common injury of the MCP that you see. And if you have inflammation of the insertion of extensor carpi longus and brevis, brevis more than longus is called as tennis elbow, which is tested by Cosen test. This is painful wrist dorsiflexion. Treatment for tennis elbow, plan A, rest plus anesthesia, if not release, surgery, if not release, steroids, if not surgery. So most of the inflammatory conditions are treated by plan A. And then if there is medial epicondylitis, it's called as golfer's elbow. If there is olecranon bursitis, student's elbow. If there is prepatellar bursitis, housemate's knee. Infrapatellar bursitis, clergyman's knee. All are treated by plan A. And there is something called as a decurvence tenosynovitis, which is very commonly asked nowadays. So if you put your thumb on the palm, close your palm, fingers, and you take it towards the ulnar deviation, the tendons whose stretch you feel is the tendon of abductor pollicis longus and extensor pollicis brevis, and they are inflamed in this disease called as decurvence tenosynovitis. Treatment is plan A. The test that we just did is called as the Finkelstein test. If there is an inflammation of the insertion of tendoachilles with retrocalcaneal bursitis, it's called as a Hank-Lund's deformity. And if there is a contracture of the palmar aponeurosis, it's called as Dupuytren's contracture. Very common in diabetic alcoholic patients. Involves the ring finger and the little finger. And if you look at the claw hand, there is hyperextension of MCP and flexion of interphalangeal joints in claw hand. Whereas in Dupuytren's contracture, there is flexion of interphalangeal joint and flexion of MCP. And that's how you should remember. You should always look at the lateral view to differentiate claw hand or Dupuytren's, because on AP view they can look the same. And if there's a deformity of more than 30 degree of MCP and more than 15 degree of PIP, then you need to operate. Otherwise, the treatment is conservative, wait and watch. And this is mallet finger, also called as the baseball finger. And this is jersey finger, opposite of mallet finger. In mallet finger, the extensor tendon goes away from the DIP, from the distal phalanx. Whereas in jersey finger, it is the FDP, flexor digitum profundus avulsion. Mallet finger is treated conservatively by a splint for 6 to 8 weeks, whereas the jersey finger is treated by surgery. And this is hallux valgus. The lateral deviation of the great toe is hallux valgus. So in hallux valgus, you have lateral deviation of the great toe. It can be bilateral. So this comes as a spotter, as an image. So great toe inflamed is gout, and lateral deviation is hallux valgus. And when I look at the shoulder, if I have initial 60 degrees, no pain, 60 to 120 there is pain, it's called as painful arc syndrome, mid-abduction pain. If your movements are obstructed throughout, it's called as impingement. And if you have a rotator cuff tear, so these three things, rotator cuff tear, the painful arc syndrome, and the impingement syndrome, have been put together in shoulder conditions, because all three are treated similar, and the treatment is plan A. But the only difference is in plan A you have rest, here you have physiotherapy, if no relief, local steroids, if not surgery. And the question that is asked is, which of the following is not true about the rotator cuff syndromes? And the answer is the steroids are contraindicated. It's not true, because they are in fact indicated. And when there is fragmentation of the cartilage with underlying bone, it's called as osteochondritis. Important are 5 osteochondritis. Severs involves the calcaneum. Isolene is the base of 5th metatarsal. Freiberg's is the head of 2nd metatarsal. Kohler is navicular. and Kienbock is osteochondritis of lunate. So this is, if you look at this image, the lunate is gone. This is Kienbock. If you look at this image, navicular is gone, called as Kohler. So these are two important osteochondritis that should come to your mind. Loss of blood supply causing death of a bone, avascular necrosis. And avascular necrosis will look more white on the x-rays. So if it involves the head of femur in the traumas around the upper end femur, proximal pole of scaphoid, we saw that the blood supply comes from distal to proximal, both these. Body of talus and the proximal pole of lunate. Now if you look at this, this is white, dead bone. Dead bone. So dead bone is white. Compare it with the surrounding black bone. This is proximal pole of scaphoid, avascular necrosis. This is upper end of humerus, avascular necrosis, white. Snow cap, as if the clad snow is wearing on the head. And when you look at the avascular necrosis of the head of femur, there is an anterolateral aspect which is defective. There is loss of abduction and internotation. The movement of the hip is different in different sectors, called a sectoral sign. When you look at an X-ray, you will see a crescentic lucency, called as a crescent sign. When you get an MRI, you will see two bright lines, called as double line sign. Your aim is to make this area decompress, to make multiple hole, called as core decompression. Or take a blood supply with a muscle, put it there, muscle pedicle graft. Or what you do routinely today, replace it. So if you look at this question, the telltale sign of ACL, C-gone fracture. Avian can occur at all except it occurs at the femur head. It does not occur at the femur neck. So when we look at the shape of the femoral head, if it is altered, there is a limitation of abduction and internotation. Normal axis, when you flex your hip, the knee goes to clavicle. If there is a damage, the knee will go to axilla, axis deviation. The investigation of choice in any hip pathology, in fact in orthopedics, is MRI. Treatment of choice, maintain the hip reduced. This is what you should remember. How do you maintain the hip reduced? Abduction. So if you want to reduce the hip abduction, remember the mnemonic RUB, reduction on abduction, that's the rule. DDH, normal acetabulum, shallow acetabulum. Normal epiphysis, small epiphysis. Normal Shenton's arch, broken Shenton's arch. Blood supply going on the head, femoral artery, blood, the vessel going there, called as vascular sign of Narath, positive. Unstable joint. Investigation of choice, MRI, screening tool, ultrasound. If you abduct it, you will feel a clink of reduction, called as ortho lani. Hip ko andar lana. It's a test of reduction. O rub. Ortho lani, reduction on abduction. Abduction, O rub. Get our selection done. O rub. Hamara selection kara dena. Ortho lani, reduction on abduction. Whereas when you adduct, the head goes out. DAD, dislocation on adduction. Barlow's maneuver, bad. So DAD is bad. Dislocation on adduction, bad. So ortolani, hip ko andar lana, bar low, dislocated. If you ask the patient to lie down and flex the knees, the side which is dislocated will be lower because it's dislocated, so it will be lower. Ali's or Galeazzi test. DDH is associated with firstborn child, female, family history, breech presentation. But some conditions are associated with it. Deviation of the foot medially, metatarsus adductus. When the sternocleidomastoid is short, your ear will touch the shoulder, chin opposite, called as torticollis, congenital muscular torticollis, associated with DDH. When your heels are prominent, called as calcaneovalgus, opposite of CTEV with DDH. So if you look at the Indian scenario, the DDH is very less because abduction at the hip prevents it. Whereas if you put it adducted, as in Western countries, is more common. That's why DDH is not seen in India. And that's why the principle of treatment of DDH is maintain abduction, Pavlik harness, or a bacillus cast or a von Rosen splint. Whatever you wish to do, the treatment is abducted. First 6 months, close reduction. 6 months to 18 months, open reduction, because the structures are inside, you need to open and release. 18 months to 3 years, femoral correction. Cut the femur, rotate the head and get it in. Beyond that, acetabular correction. So you need to identify where the acetabulum is, where the femur has to be bought, and that's how you do it. When you look at the DDH, it's seen in birth, at birth. Perthes is between 4 to 8 years of life. This is the normal epiphysis. This is avascular necrosis of the femoral epiphysis. It's usually a painless condition, self-resolving. The head can become large and can go out of the socket. There is sclerotic head along with lytic lesion in the epiphysis metaphysis called as Gage's sign. Or there can be a sagging rope-like structure over the upper end of femur called as sagging rope sign. Crescent sign, just like avascular necrosis of the femoral head, crescentic lucency. Aim of treatment, maintain abduction. When you go beyond, between 11 to 20, there can be a movement between the epiphysis and metaphysis called a slipped capital femoral epiphysis. It occurs in the growth spurt. It's a misnomer. The epiphysis does not move. It is the metaphysis that moves. It is associated with hormonal disorders like hypothyroidism. Treatment, identify and diagnose early. If you draw a line over the neck of femur, it will cut a part of the head called as normal cleans line. When you draw the same cleans line where the movement has occurred, the metaphysis has moved and the epiphysis is at a different place, there is nothing above it. It's called as Trithovan sign. Cleans line, Trithovan sign. Treatment is fixation. In old neglected cases, you need to do osteotomies. Spotter. Duchenne's muscular dystrophy. There is pseudo-hypertrophy of the calf and tongue. It's a fibro-fatty deposit inside these areas. It is not hypertrophy, pseudo-hypertrophy. Duchenne's muscular dystrophy occurs because of a mutation in the dystrophin gene, which is the largest gene in human body. The presentation is usually less than 5 years of age. There is weakness in the proximal muscles. That's why when a patient has to get up, he will take the support of his own body to get up, called as Gowers' sign. You climb on himself. This is congenital muscular torticollis. So your ear will touch the shoulder, chin opposite, called as cock robin appearance. It is associated with DDH, CTEV. And congenital muscular torticollis can present up to 3 months of life. And it is self-resolving by the age 1 in 90% cases. And if it does not resolve, between 1 to 5 you need to operate it. Because beyond 5, it will cause the facial dysmorphism. There is no benefit of doing it. When there is fusion of cervical vertebra, in fact they do not segment, then you have short web neck, low posterior hairline, restricted neck movements. And sometimes this condition is with short high scapula called as sprangial shoulder. But you know what is the most common association with Klippel-Feil syndrome? Scoliosis, 60% cases. And this is rocker bottom foot. The foot of the child is like a rocker bottom. It's a toy, and it can occur because of incorrect correction of CTEV. If you don't follow the correct order, or if the talus is vertical. Normally talus is horizontal, but if it's vertical, it can cause rocker bottom foot. And then CTEV, one of very common congenital anomalies in India. Congenital talipes equinovarus. It is combined 4 things together, remembered by the mnemonics cave. Cavus, increased plantar arch. Adduction, medial deviation of the foot. Varus, there is inversion of the subtalar joint. And equinus, plantar flexion. So there is, when you look at the components, equinus, varus, adduction and cavus. And when you correct it, first correct the cavus, then adduction, then varus, then equinus. If you do not follow this order, you will have rocker bottom foot, you just saw. And treatment principle, less than 1 year of age, by Ponseti's method, apply routine cast, correct in this order. Adduction and varus are corrected simultaneously. Up to 1 year, cast, which is above knee. If you don't achieve the correction, which is very rare, between 1 to 3 years, soft tissue release. Posteromedial soft tissue release is one of them, called as Turcos. Or you can do a total release all around, called as subtalar release, complete subtalar release, or CSTR. Beyond 3 years, since your foot is like a bean, you take out a wedge of a bone more like on the lateral side, called as lateral closing wedge of osteotomies, along with the soft tissue release, which is on the medial side, tight. This is like a bean or a club. Club is a stick used to play golf. And beyond 3 years, you do a bony procedure and a soft tissue procedure. But when you go beyond 10 years, you do fusion of 3 joints: the talonavicular, talocalcaneal, calcaneocuboid. And it is the talonavicular joint which is the most difficult to fuse. When you achieve the correction, you put the child in a CTV shoe when he's walking, and at the night you put it in Dennis Brown splint. And when the child is not walking, you put it throughout the day in a Dennis Brown splint up to the age of 6 to 7 years, because after that the recurrence chances go down. Pediatric injuries, when there is a buckling of the cortex, it's called as a torus fracture. Torus is a bend at the base of a Roman pillar, just like this. And when there is bend without a break, plastic deformation, and when there is a break only in one cortex, green stick fracture. All these are common features seen in kids. When you see a child who has got anterolateral bowing, think about a pathology called as pseudoarthrosis. What is arthrosis? Joint. Pseudo, in the bone. They have been classified by Crawford into 4 types. 1, there is a bowing. 2, bowing plus narrowing. 3, there is a cyst. 4, frank movement. So when you open that cavity, you will have fluid, you will have cartilage-like material, but not hyaline cartilage which covers the joint. That is why false joint. Treatment: stabilize and put a graft just like non-union. The deficiency decides the deformity. If you don't have radius, your hand will move towards the radial side. This is called as radial club hand or radial hemimelia. You also don't have thumb, and it's bilateral. So you don't have the whole axis. The thumb, the radius, the muscles, the vessels. If you don't have ulnar club hand. If you don't have fibula, fibular hemimelia, the commonest hemimelia. Hemi means half, melia means axis absent. There is a valgus. Look at the lateral side of the foot. In fact, the entire foot is short, but the lateral toes are almost not there. You can have a tibial hemimelia. It looks like CTV, but it's not. Because in CTV, only the foot is affected. Here, the entire limb is. Or you can have a posteromedial bowing, which is non-pathological. Self-resolving. As you go, you improve. That's why this has maximum chances to come, because the conditions which are self-resolving have more chances to appear in the exam. And then you have made lung deformity. What is made lung deformity? It is the problem in the distal part of the radius in growth, and that is why it's a palmar and ulnar deformity. So palmar angulation, ulnar deformity, that's the part of the radius that is deficient, the palmar, the volar aspect and the ulnar aspect. And that is why the lower end of ulna becomes more prominent. It's more common in females, 50% is bilateral, associated with Turner syndrome, but the good thing is the functions are excellent. And my friends, remember one thing also, coming to last thing here, polio affects the lower limbs, and the common muscle affected is quadriceps, but if you have complete palsy, tibialis anterior. Which of the following is true about Poland syndrome? So absence of deltoid, absence of teres major, radial bone abnormal, web finger, hypoplastic nipples. So C, D, E is okay because the problem is in the pectoralis muscles. Evaluate the following segments with respect to CTV. 50% cases are bilateral and in males. True. Forefoot is adducted and supinated. True. With Ponseti correction is up to 90%. True. Equina should be corrected first. No, it's last because the order is C, A, V, E. So the answer is A, B and C. Management of DDH, sequence of surgery. So what will you do first? Will you open the capsule first? Will you correct the acetabulum first, or femur first, acetabulum first, or place the head in acetabulum? So what I'll do is I'll open the capsule. The first thing I will do is I will open the joint. Once my joint is opened up, I will identify where is the acetabulum. Once I know where the acetabulum is, I will correct the femur and I will place it inside. So this is what should be the first thing I will do. So I have two answers here which can be selected. So first is capsulotomy A, then C, then B, then D. So answer is D. And then this is what you should always remember, my friends. Ortho is a specialized subject. If you do it well, you can score very well. I have tried to cover everything that has been asked in the last 5 years, along with some important questions which I have picked up. But in case, if you further feel that you should do something, go to the main videos and do those topics from there. All the very best. Thank you very much.